Hi everyone. Hi. Just give me a minute. Just give me a minute. I'll just settle down everything. Hi everyone. So welcome to Unacademy. Yes. So today I have planned for a very special, you can say, revision session. So I will be revising a lot of small topics. Maybe it may be 3 hours. You don't want for 3 hours. It may be for 4 hours also, depending upon what is your capacity and what is my capacity. Yes or no? So this has to be a marathon session. So we will just we'll continue. So what is your take? Huh? How long do you want this class to be for? Yes, tell me. You people want this class to be for? Okay. So before we start, we have a lot of things for you. Unacademy question bank is all the way more interesting now and more effective. Why? Because we have 25,000 more questions added. And not only this, the solutions are also rectified. Yes. And let us just start with this. We have a lot of subscriptions going on. You can just simply use my code and just avail the benefits. Yeah. So let us start. Okay, I'll teach a lot of things. Don't worry, Vijayalakshmi. So what is your take? What do you want? What do you people want? Let me see before starting. I'm giving you 2 minutes. You can demand your topics also. Of course, I have to do justice with all. Yes or no? So I will try my level best. So I'm giving you 2 minutes. You people can tell me what topics you have got. Already there are students who have demanded for hernia. Yes, hernia is very important. I'll teach shock, fluids and nutrition. Absolutely important topics they are. Trauma तो पढ़ाऊंगा ही पढ़ाऊंगा बच्चे. The purpose, yeah. Thank you. Shashmita, thank you. So I want this session to be the most memorable session. Yes. More on hepatobiliary, please. Look, what I will be targeting in this session is all the previous year important concept based topics. Yeah. All those topics. I'll be revising this. So this class I don't know the extent of this class, but yes, at least I will be revising all the important things. So shall we start? All good to go. So I welcome you all to this mega revision session. Yeah. So yes, let us start with this mega revision. Okay. And it's going to be non-stop. Yeah. So it's like you can say pancreas surgery. Yeah. So we are going for a pancreas surgery. Okay. Let us start. But the rule is you will not leave, huh? Because it may be a possibility that you are not liking one topic, but try to listen to it. But it will definitely benefit you. So I will start from the weightage part. The maximum weightage that we get is actually maximum weightage is given to the general surgery part. So yes, I will start with the general surgery first. I will start with general surgery and I'll complete each and everything. Why? Because at least 8 to 10 MCQs you can get. Yes, but I'm very ordinary person, bache. So you people are more intelligent and hardworking. You will be definitely more successful. Yes. So let us start this session. Okay. So when we talk about general surgery, the first thing that I'm going to start with is the concept of shock. This is again very important. Since this is a topic in demand, yes, we'll get. So shock is the most important topic. You can always expect at least 1 to 2 MCQs. But in shock, since this is a revision, we have to complete everything. So I'll not be teaching everything. Shock, you have to understand 2-3 things. First is the concept of shock index. I hope you know shock index is defined as heart rate upon SBP. Is that clear or no? And then we have the second thing, modified shock index. Modified shock index is defined as heart rate upon mean arterial pressure, MAP. Is that clear or no? You often get questions how we interpret this shock index. इस पे भी question आता है. So when we talk about interpretation of the shock index, yes, there could be a scenario when the shock index could increase. There could be a scenario when the shock index could decrease. बच्चे, when it will decrease, answer is simple, straightforward. It is only going to decrease when the numerator is going to fall, that is bradycardia. Remember, when it is going to increase, it is going to increase when the numerator is going to increase, that is tachycardia. Let us see it to be very simple. What are the conditions where you have tachycardia? Let us see what are the conditions where you have tachycardia. The first is hypovolemic shock. Hypovolemic shock, is that clear or no? So hypovolemic shock, this is point number 1. Second, then same thing, that is cardiogenic shock. Cardiogenic shock, yes, less blood, more you can say rounds, so more the heart rate is increased. Then SIRS induced tachycardia, yes, so that is septic shock. Septic shock, yes or no? Septic shock. Let us try to understand. When we talk about decrease, किस factor में decrease होगी? What is a factor associated with bradycardia? Answer is neurogenic shock. Neurogenic shock. Let us quickly compare all the different forms of shock. And now today I'll only discuss hypovolemic shock and move forward. So let us have a quick overview of the shock. So when we talk about comparison, let us talk about the comparison of different type of shocks. Comparison. When we talk about comparison, the first thing, बच्चे कुछ भी नहीं छूटेगा. That is why I have taken it for 3 hours. Every topic I will be touching. Every topic. Don't worry. When I have promised you, it's my promise. बच्चे, surgery will be done. So this is a surgeon's commitment. ऐसा नहीं कि 3 hours up, the surgery is down. If it takes even 5 hours, I am there to complete it with you. Don't worry. I will be doing that. So when we talk about comparison of different type of shock, today you will see a surgeon's real attitude and passion. So the first thing is hypovolemic shock. When we compare hypovolemic shock versus cardiogenic shock versus neurogenic shock versus septic shock, how to evaluate it? Yes, how to evaluate it. So the first point of comparison is the heart rate. When we talk about heart rate, it's going to increase in all except it is going to decrease in neurogenic shock, because we know that in neurogenic shock there is loss of sympathetic tone. So sympathetic tone, there is loss. Try to understand. Therefore bradycardia. Then next is respiratory rate. If we talk about students respiratory rate, one very important thing that you have to understand is that respiratory rate is going to rise in all except in case of neurogenic shock, when it is going to get decrease. Is that clear or no? Then the third is peripheries. If you talk about peripheries, you have to understand that shock is a state when you give first priority to your important vital organs. Therefore, in all the cases of shock, there is increased peripheral resistance. Is that clear or no? There is increased peripheral resistance. So there is increased resistance. And how the resistance has been increased? Because there is vasoconstriction. And try to understand. Therefore, they are cool. Same case, there is increase in resistance. Therefore, vasoconstriction. Therefore, cool. Except in case of neurogenic shock. Since there is loss of sympathetic tone, there is increase in capacitance. So there is peripheral pooling of blood. So therefore there is vasodilatation, and therefore you get to see what type of extremities, students? Warm type of extremities. Next is, try to understand, when we talk about septic shock, initially it is the effect of bacteria or the toxin, that is, it is going to give you that warm state. Later on, as the shock overtakes, it is going to behave like a hypovolemic shock. So later on, it's always a cool. So initially warm. Why? Is it due to vasodilatation? No, it is not due to vasodilatation. It is due to toxin. So it's a viral toxemia. Apart from this, what else you compare? CVP. Remember, CVP is going to fall in all of them except the case of cardiogenic shock. In case of cardiogenic shock, it is going to increase. Just try to understand what else is very important. Arjun has written, just wanted to revise the notes. But yes, you'll revise the notes also. You'll get to understand lot more important points also. Is that there? So let us see what else. Sepsis. or you can say infection. Infection is seen only in one. What is it? Is not seen here, not seen here, not seen here. In case of septic shock, it is seen. When we talk about MVOS, what is MVOS? Mixed venous oxygen saturation. This is mixed venous O2 saturation. When we talk about mixed venous O2 saturation, what is happening, students, here? Try to understand. It is going to fall. It is going to decrease in hypovolemic shock. It is also going to decrease in the cardiogenic shock. Remember, less than 50% indicates ongoing shock, ongoing hypovolemic shock. Similarly, in neurogenic shock, it is going to increase. Why? Because in neurogenic shock, lesser tissue extraction by the tissue, lesser oxygen extraction by the tissues. Why? Because blood is not reaching them. In septic shock, why there is lesser tissue, lesser oxygen extraction? Because the blood is going, but the toxemia is not allowing this metabolic uptake. So remember, more than 70% indicates ongoing shock. So before you stop the process of resuscitation, you should be damn confident that yes, is your patient settled down as far as the cellular component of oxygenation is there or no. So you know that shock is monitored at two levels. One is the cellular level and one is the clinical level. So merely by seeing the urine output, you cannot say that I should stop the process of resuscitation. MVOS in fact is a very important indicator. Apart from this, let us quickly have an overview of the management. When we talk about the management, fluids are to be given in hypovolemic shock. Remember, if you give too much of fluid, the patient will have hemodilation, or you can say dilution, and thus DIC will precipitate. So excessive grades like grade 3, grade 4, they will also require what? Blood transfusion. So blood transfusion is required. When we talk about the cardiogenic shock, remember, you have to go for fluid restriction. Students, fluid restrictions. Along with that, awesome Shashmita, awesome bache, awesome. So fluid restriction, along with that, you have to give inotropes. Dopamine, yes or no? Dobutamine, you can go for adrenaline, noradrenaline. Inotropes are very important. In case of neurogenic shock, students, I'll discuss that part. In case of neurogenic shock, remember, you have to give fluids also. You have to give inotropes also. In case of this septic shock, you have to give fluids. Along with fluids, you have to give antibiotics, and along with this, you might require some inotrope support also. Now, this is a very common question which is asked from you people. Sir, when we talk about the shock, what is the initial fluid of choice? The initial fluid is always crystalloid. Is that clear or no? So initial fluid is always crystalloid. Remember, colloids are absolutely contraindicated. In first 12 to 24 hours of hypovolemic shock. Remember why? I will discuss this point in fluids only. Remember one or two more important things when we quickly discuss the concept of hypovolemic shock. Hypovolemic shock, cardiogenic shock, everything we are going to give only 5 minutes. So it's a rapid fire session. We have to see. Awesome bache. Awesome Shashmita. Yes, this is right. So when we talk about cardiogenic shock, quickly we will see cardiogenic shock is of 3 types. Cardiogenic shock can be compressive version of cardiogenic shock. Remember, it could be obstructive cardiogenic shock. The third variety is a functional cardiogenic shock. So we have 3 types. We have compressive cardiogenic shock, we have obstructive, we have functional cardiogenic shock. What is what type? Let us try to understand. A compressive is compressive. If you talk about compressive, this is associated with external compression. And when we talk about external compression, what are the examples? What are the associations? This is associated with cardiac tamponade. Yes or no? This is associated with tension pneumothorax. In fact, in order to understand the concept of tension pneumothorax, you should be knowing one very important thing, that tension pneumothorax का तो hallmark feature ही होता है hypotension. And why this hypotension occurs? Because of the decrease in cardiac output. Yes, let us try to understand the concept of obstructive. Achha, one more thing, positive pressure ventilation also. Obstructive variety of cardiogenic shock. So what Gino has asked, crystalloid preferred over blood if given an option? Absolutely, bache. The first line option is crystalloid. I will also give you the damage control resuscitation also. I will teach you damage control resuscitation. So all your confusions will go as far as the resuscitation pattern of a sick patient is concerned. Obstructive cardiogenic shock is due to obstruction to flow. This is due to obstruction to flow. So quickly batao bachcho, what are the causes of obstructive cardiogenic shock? So what could be the obstruction? Students, the main is, it could be aortic stenosis, it could be pulmonary stenosis, tricuspid stenosis, mitral stenosis. Apart from that, there could be a late stage of tension pneumothorax when there is kinking of the vena cava. Yes or no? So tension pneumothorax is a condition where you get to see both the types of cardiogenic shock. Initially you get to see the compressive version. Later it is the obstructive cardiogenic shock. Always remember, this is obstructive cardiogenic shock, which is the most common cause of death. Yes, I hope you remember this. Old star, everyone remember. So the most common cause of death in you can say tension pneumothorax is obstructive version of cardiogenic shock. We will see when we discuss the thoracic trauma. Is it clear? When we talk about the functional type, this is associated with functional pathology. This is associated with functional pathology, and example could be ischemic heart disease. So example is ischemic heart disease. Very quickly I will go to the next, hypovolemic shock and its grading. This is very, very, very important. Students, you just have time to listen and enjoy and feel this subject. So you will not have time to think and yes, just feel that yes, you are reading something. So hypovolemic shock, if you talk about the grading, we have 4 grades: grade 1, grade 2, grade 3 and grade 4. The first question, remember, the first question is, how do we decide on the basis of percentage? So percentage blood loss. Answer is, remember the scoring of a tennis match. Yes, less than 15, 15 to 30, remember more than 30, up to 40 and more than 40. This is really very, 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 very important, and that is why this is known as tennis classification. So this classification is also known as tennis classification. ये मैं नहीं कहता, this is written in books also. Try to understand one more thing. On the basis of ml blood loss, if we talk upon the basis of ml blood loss, this is also very simple and straightforward. Remember, less than 750 ml to 1500 ml is grade 2. More than 1500 ml up to 2000 ml, and remember more than 2000 ml. Yes, gone. Next is yes, Babita, GIT will also be covered. I will give maximum time to trauma, general surgery, and you can say the plastic surgery, that is burn part. After that I will give a decided 45 minutes. Don't worry, even if it is not, we will have a second session, it will be covered, everything will be covered, don't worry. Dada is not going to leave you halfway. Then let us talk about heart rate per minute. When we talk about heart rate per minute, less than 100, more than 100, more than 120, more than 140. Students, try to understand one very, 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 very important thing, that grade 1 hypovolemic shock is more of a compensated version. Remember, it is a compensated version of shock, and this is the most lethal thing that happens. Why? Because the patient is having a grade 1 and patient says, doctor, I want to get myself discharged. Hamara patient theek hai, the hospital is overcharging. I think they are going to add the bill. You should explain them that don't go, because this is a time when your patient will again revert back. If you see the patient is having all the parameters normal. So that is why. Yes, let us move forward. Then we have systolic BP. If we compare the points on systolic BP, Normal for grade 1, normal for grade 2, it falls from grade 3 onwards. But if you compare the arterial blood pressure, mean arterial pressure, which is in fact the most important, when you put a femoral line and you start gauging the pressure, that is actually how you get the exact. So you see a normal grade 1, but from grade 2 onwards, it starts to fall. It starts to fall. Then let us see the urine output. Let us see the urine output. If we talk about grade 1 patients, this is ml per hour. Now, what is the basis of this calculation? Let us assume the normal person to be 60 kg and let us see the normal rate to be 0.5 ml per kg per hour. 0.5 ml per kg per hour. How do we decide it? Students, this is more than 30 ml. This is 30 to 20 ml per hour. Yes or no? Then 5 to 15 ml. 5 to 15 ml. And this is negligible. This is nil. Is that clear? This is how we decide grade 1, grade 2, grade 3, grade 4. The next very important point is respiratory rate. This is again in ml. Respiratory rates per minute. So remember, 12 to 20 is grade 1. 12 to 20 grade 1. 20, more than 20 up to 30 grade 2. More than 30 up to 40 grade 3. Now this is a trap, because you must be thinking now that more than 30, more than 40 should be grade 4. No, anywhere where there is persistently elevated breath count beyond 35, it could be grade 3 also, it could be grade 4 also. It depends what are the other features. What are the other features? Like suppose if I say that respiratory count is more than 37 and heart rate is 128. Tell me what is this grade? Tell me what is this grade of hypovolemic shock? Same question, heart rate 148. What is this grade of? So you have to see whenever there is confounding factor, whenever there is any confounding factor, you have to look at the other parameters also. So this is very good. Awesome Anjali. Grade 3 पहले वाले के लिए ये grade 3 हो गया. क्यों? क्योंकि 37 can be grade 3 also, grade 4 also. So you have to see 3 for one, the first one, and this is the grade 4 now. Is that clear? So let us quickly move forward. Then next is mental status. Mental status. When we talk about the mental status, this is oriented. This patient is anxious. This is restless. And this is confused, either confused or you can say lethargic, either confused or lethargic. Next is the management. When we talk about the management, the first thing that you have to understand is, yes, they all require fluids. And what is the fluid of choice? The fluid that we require is actually the crystalloid, and the crystalloid of choice is 0.9% NaCl. 0.9% NaCl. Remember, for grade 3 and grade 4, you prefer to go for blood also, because there is a lot of dilution. Remember, when I discuss the resuscitation pattern, you should always remember the concept of damage control resuscitation. Quickly, what is the concept of damage control resuscitation? This is very important, and very frequently you have got the questions on this. The damage control, 2 बार आ चुका है पिछले 2 सालों में. So damage control resuscitation, what is the concept? When a patient comes to trauma bay in a state of shock, how to manage that patient? Remember, control your emotions. Don't put one IV line here, one IV line there, and start with lot of fluids. Remember, have a controlled volume of fluid given. So limited infusion of crystalloid. Infusion of crystalloid. Remember, up to 2 liters. You should not give beyond 2 liters. And of this 2 liters, you can give 500 to 1000 ml as a bolus also. Is that clear or no? So try to give 500 to 1000 ml as bolus. Remember, if the patient is not responding to this, don't keep on adding. Already the patient is in shock, patient has lost blood. Therefore, if you keep on adding the fluid, you are actually converting this fluid, this blood into a diluted something. I cannot say. It could be lassi, it could be Pepsi, it could be Coca-Cola. But when you add too much of fluid, there is so much of hemodilution. that the patient will have DIC. Is that clear or no? So limited control, limited infusion of crystalloid. The next thing is replace blood by blood. Therefore, blood transfusion, blood or blood product transfusion. Is that clear or no? So blood or blood component transfusion. This is the second important strategy. If a patient is losing blood, don't try to add more stress by increasing the blood pressure. Try to understand. I still remember I was operating on a retroperitoneal tumor, and all of a sudden there was a bleeding from a vessel. I couldn't trace what is that vessel, and there was that operative site was completely filled with what? Blood. Now this is the problem, because I could not place the grasper also. Kahan control kare, kya kare? I was just clueless. Then I saw the anesthesia machine, and the blood pressure was 190 by 120. Now why this was so much? First of all, when you are doing a laparoscopic surgery, CO2 actually causes what? Sympathetic stimulation. My next target was, I requested the anesthetist to reduce down this blood pressure, because higher the pressure, more will be the blood loss. So I am allowing this hypotension, and this is what is the concept of permissive hypotension. Awesome, bachcho, awesome. So permissive hypotension. So permissive hypotension, the blood pressure went down, the blood flow went down. I was able to see, and I put a what? Vascular clamp there. So permissive hypotension. Again, what should be the limit? Huh? So the target map, mean arterial pressure is kept around 65 to 70 mmHg. इसके नीचे नहीं ले जाते हैं, समझे कि नहीं? इसके नीचे. So target mean arterial pressure is 65 to 70 mm. Do you know why? Because cerebral perfusion pressure below. देखो, your extremities will not have any problem, but cerebral perfusion pressure below 65 is actually going to cause cerebral ischemia, which might be an irreversible event. Is that clear? No. So CPP को इसके नीचे ले ही नहीं जा सकते. This is very important. CPP. This is doctor, whatever you name is. बच्चे, आप 30 वो बोल रहे हो, but blood flow rate है 30 ml per 100 grams per minute. If the blood flow goes below that, that is what. But cerebral perfusion pressure should be maintained at 65. इसके नीचे गया तो बच्चे, you will have all those neurological, you can say neurological disorders developing, or neurological deficits to be developed. So next is permissive hypotension. Next, if you want the fluid, give hypertonic fluids. Yes or no? So trial of hypertonic saline. So trial of hypertonic saline. Thank you, bacho. Thank you. It's all your love. That is why I am here to revise this. I know many of my kids are not with me. Many of my kids come to my special class, but I remember the fact that yes, I have to do justice with all of my kids, even if they are in Unacademy or even if they are in another platform. It's my responsibility to come up at the last stage and give them those last minutes of what? Finishing touch. So trial of hypertonic saline. Trial of hypertonic saline. Why? Because it will give you more volume expansion. It will give you more volume expansion. And next is use of cryoprecipitates. Use of cryoprecipitates. Yes. So use of cryoprecipitates, or students, or recombinant. Yes, factor 7. Recombinant factor 7. This is very, very, very important. Yes. This is very important. Recombinant factor 7. It has been seen that adding the recombinant factor 7 actually decreases the bleeding. Again, there is one more thing along with that. You should always give tranexamic acid 1 gram. Use of tranexamic acid, liberal use of tranexamic acid 1 gram. So this is damage control, resuscitation also covered in this part. When we are talking about damage control resuscitation, I will quickly discuss damage control surgery also here. Yes. Damage control surgery. Yes or no? So damage control surgery. I will not discuss complete topics, because बच्चे ऐसे तो फिर सारे topics हो नहीं पाएंगे. We have to do justice with all. Is that clear? No? So let us talk about the next topic, that is damage control surgery. The term given by Rotando. The term given by Rotando. I'll just discuss it in 2 minutes. What is damage control surgery? The principle of damage control surgery. The principle of damage control surgery is to control bleeding. It is to control bleeding and to control infection. So control bleeding and to control contamination. How do you control bleeding and how do you control contamination? Let us try to understand. But before that, why you want, what is your aim, what is your intention? The intention is to check lethal triad. What is this concept of lethal triad? Let us quickly try to understand this concept of lethal triad also. What is that lethal triad? It is a combination of hypothermia. Remember, hypothermia, this is the worst thing that a body wants. Why? Because hypothermia is actually going to impair the coagulation cascade by disturbing the enzymes which are required for the activation. Is that clear? Hypothermia is the most lethal thing in coagulation profile. It's going to damage the coagulation cascade. The second thing which is damaging is your metabolic acidosis. So metabolic acidosis. So acidosis is again going to impair the coagulation cascade, and these things in turn will result in a coagulopathy. Once this vicious cycle starts, it is not going to stop and it is going to continue again and again and again, and the death is inevitable. Now, a patient has been brought to you with a sick, deteriorated condition. The accident or injury happened 3 days back. For 3 days, the patient was admitted in some hospital, and then the patient is referred to your hospital or maybe to a medical college, and now you want one answer to yourself. What is that answer? That the answer is, if I try to operate on this patient, this will die. He will die because the patient is actually very sick. If I don't operate, then also patient will die. Why? Because the patient now has 2 injuries. The surgeon has to counter 2 injuries. First, the original damage which has happened, maybe because of the accident, and then the second injury because of the neglection or delay, the patient is having a physiological injury. But for anesthesia, there is no surgeon who has ever killed any patient. कौन मारता है? Anesthetist. Jokes apart. Yes or no? So वो हमारी टांग खींचते हैं, उनकी टांग खींचते हैं. So it is anesthetist who will say, oh my God, this patient is so much deranged. If I give anesthesia, I will die. Then what to do? You want to operate, you are desperate to operate, you cannot operate. अब क्या करते हैं? In that way, you decide to cut short the duration of your surgery, and there comes the concept of abbreviated laparotomy. Is that clear or no? And that gave the concept of DCS. So there are phases. I will discuss, students, the phases. Yeah, phases of DCS. Phases of DCS. Yes, ऐसा नहीं बच्चे. Don't say. But anesthesist को देखा ना? Anesthesist वो हमारे लिए बोलते हैं, हम उनके लिए बोलते हैं. बच्चे शाम को साथ ही में बैठते हैं, ऐसा कुछ नहीं. We all have a good harmony. So when we talk about the phases, the phase 1 is the phase of abbreviated laparotomy. Abbreviated laparotomy. What are you doing in this abbreviated laparotomy? Yes, are you correcting the damage? No, you are controlling the damage from expanding. So how do you control the damage? So controlling of the damage, you will do a laparotomy. You will see wherever the bleeding is, wherever there are bleeders, you will stop those bleeders. Yes, you will ligate them. You will not see what has happened. You will see from where the bleeding is happening. And then what you can do, you can wash, you can give a copious lavage to the abdominal cavity or wherever, if you have done a thoracotomy there, and then you put a drain. Yes. So how or what was the intention of putting the drain? The intention of putting the drain was to counter the contamination from what? Propagating and developing what? Sepsis. Is that clear? No? So patient would have developed a septic peritonitis very soon. So controlling the damage, and that is why you have done this. Now the question is, sir, आपने तो surgery करी नहीं. You will require a second surgery to be done. I said yes. So are you going to repeat this surgery again? No. The answer is no. So what am I going to do? I'm going to go for temporary closure of the abdomen. So temporary closure. And what is this temporary closure known as? This temporary closure. This is what is referred as Bogota bag. Bogota bag. So Bogota bag. बच्चे वैक पैक नहीं करते हैं यहाँ पर. देखो वैक्यूम जो वैक्यूम रिलेटेड पैकिंग होती है वो इसमें नहीं करते हैं. बाय ट्राई टू अंडरस्टैंड रिदमा. बिकॉज इफ यू डू अ नेगेटिव सेक्शन ड्रेसिंग बैक पैक करोगे तो क्या होगा, इट विल सक द बावल इनसाइड. यू हैव नॉट डन अ फेशियल क्लोजर, सो बावल विल गेट इंजर्ड और इट विल गेट abraded. सो वैक्यूम असिस्टेड क्लोजर यहाँ नहीं करते हैं. वी गो for that bagota bagging. We go for a bagota bagging. Now what is this offsite sandwich, students? Offsite sandwich कुछ नहीं है, ये corporate के चोचले हैं. What is that corporate चोचला? This is commercially available bagota. What is that? This is offsite material. You know why offsite is chosen? Offsite is chosen because it is transparent. Is that clear? This is a transparent. So it's a transparent plastic, that is why it is chosen. हम क्या करते हैं, यूरो बैग को खोल के लगा लेते हैं. And then what is in center? This is the abdominal sponge. Yeah, this is the abdominal sponge. What is this abdominal sponge going to do? This abdominal sponge is going to absorb all the suction. And then what you do? You put some flat drains. You must have seen those flat drains when you especially use it for pancreatic surgery. 2 days before I have shown the flashcards also on the special platform where I have discussed this. This is a Jackson-Pratt drain. So remember, Jackson-Pratt drain is a flat drain. It's a flat drain. Flat नहीं होता है, बस इतना part उसका flat होता है, बाकी तो उसकी tubing ही होती है, बाकी तो उसकी पूरी tube होती है. Yes or no? So it's not a flat. Only the initial part is actually flat. So this is how the system is put. One layer of offsite under. Between that, it's abdominal sponge. One is on the out. This is what is the concept of you can say offsite sandwich. This is what is known as offsite sandwich. Anyways, now once this happens, this is what is phase 1. Then we go to phase 2. What is phase 2, students? Phase 2 of the patient is in ICU. Why the patient is in ICU? What is the aim? Bache, you have corrected the physiological injury? No, no. Remember, the resuscitation of the patient starts in OT itself, but the majority of the resuscitation is continued in the ICU. There was a question where the question was, where is resuscitation started? Answer is, it is started from OT itself. The aim is to control the physiological damage. So to control the physiological injury. Is that clear or no? And what is that physiological injury? That is represented by the lethal triad. So now what you have done, this is phase 2. Once the patient is stable, it may take 48 hours, it may take 72 hours. Once the patient is hemodynamically stable, you go for a second look laparotomy. So this is the phase of definite surgery. What do you do in definite surgery? You do a second look laparotomy. But second look laparotomy is done by, you will now see what is the definite place where you have to do the surgery, and this is where the damage correction is done. Is that clear or no? So damage control kahin par karte hain, damage correction kahin par karte hain. So this is the place where you do the damage correction. Remember, earlier this was the last thing. Abhi kya kar diya hai? The new concept is, what is the new concept? We have phase 4 also. What is phase 4? Bache, except in exam, and until and unless they don't ask you, you will not write. Phase 4 is the phase of abdominal closure. Is that clear or no? Earlier, this part was a combined part of the phase 3. Is that clear or no? So phase 4, what is also new is phase 0. What is phase 0? This is the phase of patient selection and preparation. Is that clear or no? These are 2 new updates that you should all be knowing. I hope this part is clear to everyone. Yes, this part is clear to everyone. Let us quickly move forward and let us discuss about the indications for damage control surgery. Students, this topic is really very important. So let us talk about this concept of damage control surgery. The first thing that you have to understand about damage control surgery, there could be the anatomical indications. What are the anatomical indications? First is complex abdominal injury, complex abdominal injury, complex vascular injury. So unstable patient, of course you will have to. So जरूरी नहीं कि बच्चे हर unstable patient में. Utkarsh, try to understand every unstable patient doesn't mean that this patient will be taken for damage control. Suppose someone has stabbed someone with knife, that patient is losing blood, so patient is in shock. इसका मतलब ये नहीं कि you will not operate, you will operate. So remember, damage control surgery is done where there are two injuries. One is the anatomical damage also, and the another is the physiological damage also. वहाँ पर करते हो, समझो इस चीज को. There's a hairline difference, but in fact it's very important. So complex abdominal injury, then unidentified abdominal injury, and unidentified vascular injury. So unidentified abdominal injury, unidentified vascular injury. What else? Bache, when second look laparotomy is required, second look. So this is the functional indication now. Have you heard of mesenteric ischemia? Many a times after doing embolectomy or thrombectomy, you do a second look laparotomy. Why? Because there may be the impact of ischemia that the bowel has undergone necrosis. At that time when first surgery was being done, the bowel was maybe dusky, but you gave one chance to the bowel rather than going for extensive resection. Agar ye bowel bach gayi to acha hi hai. So that is also a case where the patient was not having lethal triad, but you decided to go for a second look surgery. So second look surgery required. Or the second is for loss of domain hernia. What do you mean by loss of domain hernia? What is loss of domain hernia? This is very simple, straightforward concept. Loss of domain का मतलब होता है कि suppose you must have seen in your colleges ना, there is a patient coming and he is hiding something. You think that he has brought a gift for you, and when he just removes the pant or removes that traditional lungi or shalwar, whatever he is wearing, you see something magical. Yeah, itna bada kuch hai. Yes or no? And then Dadu is looking here and there, is not telling you. And then you ask, how old is this? Nahi sir, abhi 5-6 saal hue. Then you abuse him or you request him or you please him, batao to sahi. Then he will tell this is 45 years old, 60 years old. For last 50, 60 years or 40 years, he was having the bowel outside the abdomen. Yes or no? So abdomen कहेगा, imagine a scenario when you don't return to your home for 20 years. आपके घर वाले कहेंगे यार इसका रूम रख के करेंगे क्या? Yes, इसका रूम भाड़े पे उठा देते हैं या फिर इसके रूम इसकी सिस्टर को दे देते हैं या ब्रदर को दे देते हैं. And after 20 years all of a sudden you come back and say नहीं मेरा कमरा कहाँ है, मेरी साइकिल कहाँ है, मेरी गर्लफ्रेंड कहाँ है, मेरा जुगाड़ कहाँ है. So बच्चे, then the problem will arise ना. For a long time you were not there. So when you reduce this much of hernia, when you reduce this much big hernia after so many years, what will happen, students? There is no space. The problem has to arise. An abdominal compartment syndrome will happen. तो बच्चे ऐसे में आप एकदम से आगे कि नहीं यार ये तो नहीं हो सकता. Then what do you say? What do you do? Instead of going for the abdominal closure, go for a temporary closure. Is that clear? Put a Bogota. Wait for 1 week. Abdominal wall has that beauty that it can become lax, and then yes, you can reduce it, and after some time you can go for. Are these points clear or no? Then the third category of indication is physiological indications. So what are the physiological indication? Yes, the first is temperature. Remember, classically hypothermia is defined as less than 34 degrees centigrade. Severe hypothermia is defined as less than 32. But in case of abdominal trauma, if the temperature goes below 35 degrees centigrade, 35 degrees centigrade se niche jayegi, you will have to take a call that yes, this is a case where the coagulation cascade will be impaired. You will call as hypothermia. Then pH less than 7.2. Yes or no? Third, lactate levels more than 5 nanograms per ml. Yes, that is considered to be severe. Yes, 4 to 5 is actually considered to be severe. Then fourth is Prothrombin time more than 16 seconds. Yes. APTT more than 60 seconds. Yes. Apart from that, more than 10 units blood transfusion done. So more than 10 units blood transfusion done. Actually, you are dealing with what? Yes, massive blood transfusion protocol. Massive blood transfusion protocol. Seventh is, students, seventh is severe sustained hypotension. When we talk about severe sustained hypotension, students, try to understand 2-3 things. What is the criteria for severe sustained hypotension? This is less than 60 mmHg, less than 60 mmHg, even after aggressive resuscitation. So even after more than 90 minutes of resuscitation. What is sustained hypotension? BP or hypotension not amenable to resuscitative, or that is not improving over the time. But severe sustained तब बोलते हैं जब less than 60 mmHg चला जाता है, that too for a prolonged time. Remember one again very important thing, when you are talking about the hypotension, yes, what is the relation of the pulse? What is the relation of the pulse and the minimum systolic blood pressure required? Minimum systolic blood pressure required. बच्चे कैसे पता लगता है? For peripheral pulse, किसी भी peripheral pulse की बात करूं, जैसे radial pulse, yes or no? Radial. So radial artery pulse, minimum 80 mmHg is required. If the radial is not palpable, इसका मतलब है कि blood pressure 80 के नीचे है. Is that clear? Then femoral, the next is you check for the femoral. If femoral is not palpable, that means the blood pressure is less than 70, and then you check for the what? Jugular. Yes or no? Jugular. Bachche, carotid, if carotid is not palpable, I'm saying jugular, carotid, if carotid is not palpable, it is 60 m, less than 60. So this is even after excessive resuscitation, the carotid is not palpable. इसका मतलब है कि patient is having sustained hypotension. You have to go for surgery. So this is all about damage control surgery. The next topic will not stop, will not take any rest. We will go for the topic of fluids. Is that clear? Fluids. Is this lecture available for tomorrow offline? I don't know. बच्चे देखो इतना technical चीजें तो मैं नहीं जानता. Only Unacademy people can actually tell. But in fact, it was my demand. I wanted to conduct a mega revision session so that we can revise a lot of things. So when we talk about fluids, you have 3 important questions. And the answer to the 3 important questions, students, if you get, you will never have problem. What is the first question? The first question is what to give. The second question is how much to give. Yes or no? And third is how to give. That means rate also. But you try to understand, we have 3 important things. देखो, these are golden words. Shiva, try to understand. देखो, अगर मैं PDF भी दे दूंगा आपको, तो बच्चे आपने efforts तो करे ही नहीं. Yes or no? Yes. So if you really like it, of course, you have a lot of programs going on in Unacademy app. You can download the PDF there. But YouTube को PDF शायद I am not that proactive that I will generate a PDF from this and distribute. मेरे से वो हो नहीं पाता. Actually, it's not. I don't want. But I'm not technically that sound. Yeah. When it comes to that much of efforts. So fluids. So there are 3 things that you have to understand: the choice of fluid, the volume requirement, and the rate requirement. These 3 things are very important. Let us try to understand. The first thing that we are going to discuss is how to estimate the volume requirement. So the calculation of volume requirement. When we talk about calculation of volume requirement, then the first thing that you have to understand, we have 2 things. The formula is in volume in ml per day, or you can have volume in ml per hour. So volume in ml per day and volume in ml per hour. Let us talk about this now. Yes. The first thing that you have to divide, in order to make the calculation easy, we have divided it into kgs. Yes. like first 10 kgs, the second 10 kgs, and further kgs. So first 10 kgs, the second 10 kgs, and further kgs. Yes or no? Yeah. Try to understand this. बच्चे first 10 in volume in ml per day क्या कैसे याद रखते हैं? 100 ml per kg for first 10 kgs, 50 ml per kg for second 10 kgs, and 20 ml per kg for further kgs. कैसे? Isn't it easy? 150 20, 150 20. Yes. Then in ml per hour. So we have 4 ml per kg for first 10 kg. Then we have 2 ml per kg for the next 10 kgs. And then we have 1 ml per kg for the further kgs. So 4 to 1, 150 20, 4 to 1. This is very easy. We can just simply calculate. Remember, like if I say calculate, the example is calculated for 80 kg. 80 kg. Yes. 80 kg. Yeah, this is the name of that formula. Yeah. Okay. So 80 kg individual. फटाफट मेरे के लिए दोनों versions में calculate कर दो. So पहले 10 के लिए 100 into 10. अगले 10 के लिए 50 into 10. Then remaining कितनी kgs बचे? Remaining बचे 60. So 20 into 60. So this is 1500 and this is 1200. So total is to be 2700 ml per day. I hope this is clear to everyone. When you talk in ml per hour. So for first 10 kgs 4 ml. For next 10 kgs it is 2 ml. For remaining kgs it is 1. So the answer is, this is found to be 40 plus 20 60, 60 plus 60, that is 120 ml per hour. 120 ml per hour. Isn't it easy? Very easy. Next is, once you have calculated the volume, the next challenge is to calculate the rate. Now this is again a jugaad. Yeah, like Shashmita has already said, this is a jugaad. So rate estimation. So volume estimation हो गया. Rate estimation is in drops per minute. It's DPM, drops per minute. When we talk about drops per minute, the most important thing that you have to understand is there are two formulas for this. Two formulas. Drops per minute is equal to number of hundreds in ml per day. Hundreds in ml per day. Number of hundreds in ml per day. This is how we say drops per minute. What about the another formula? This is volume in ml per hour divided by 4. Volume in ml per hour divided by 4. So imagine if I say 3200 ml per day. The other thing you can say, जो भी volume, the volume in ml per day divided by 10 कर दो, कोई दिक्कत नहीं है. Yes or no? Divided by 100. It's one and the same thing. So ये कितना आ गया बच्चे? 3200s. Yes or no? If I say 4800 ml per day, how many drops per minute? That is 48. Yes, Shashmita, you are just reminding me of that class that whenever I teach in class, I say always the swag should be maintained. Yeah, the swag should be maintained, and you should tell sister in that complete swag. It's 32, it's 48, and so that is what you. It shouldn't be like when you order sister, please start 3200 ml, and then she's looking at your face, doctor, tell me how many drops, and then you are asking for a paper pen. Yeah, so you should have that orientation, that swag of a doctor. Say sister 3200 ml and 32 drops per minute. So that creates, now, oh my god, doctor is so intelligent. Yeah. So next is, suppose in ml, 100 ml per hour. So how many drops per minute? Yes, it is 25 drops per minute. Yes. So सबसे important चीज होती है ना एक डॉक्टर की लाइफ में, that is the swag. Yeah. Like if you talk to me about surgery, if you talk about surgery में कुछ नहीं है बच्चे, कुछ भी नहीं है. The only thing that a surgeon has is a swag, और कुछ भी नहीं है. The swag. ज़्यादा मत बोलो, कह देगा अभी ऑपरेशन करना है. Yes or no? If you see, when the patient comes to your chamber, when the patient comes inside your chamber, yes, he is just mesmerized by that swag. Yes, वो swag ही तो है, कहते हो कि नहीं, if I want to operate, if you get to operate from me, now I have started two things. Whenever a patient comes to my hospital and they say, okay sir, what will be the charges of this surgery? Yeah, so I always say, if you want to get operated from me, I will take 90,000. If you want to bargain, I can call a surgeon and get you operated. No sir, मतलब कुछ तो होगा ना, swag तो होगा. So you should have that confidence to speak like this. Yes or no? तो कहेगा नहीं नहीं डॉक्टर साहब आप ही से कराना है, आप 1500 ले लेना, डोंट, वो आपके यहाँ जो फेलोशिप के लड़के वड़के हैं, you know, I started with lot of training courses for MBBS students also, lot of certificate courses. So they are again going to start at my new hospital in Dwarka. So there are a lot of students. So before OT, today, before OT, one of the attendants came inside the OT, said, Doctor साहब आखिरी बार कह रहे सर बच्चों से मत कटवाना, आप ही करना जो करना है. So that is again a very interesting thing, na. That's again very interesting. Anyways, so we have seen the rate estimation, we have seen the volume calculation. The last thing that we are going to see is the fluid selection. So choice of the fluid. When we talk about the fluid, मतलब पेशेंट डरा हुआ है, उसको लग रहा है ऐसा ना हो बच्चों को दे दे खेलने को, हाँ. सो पेशेंट इज आल्सो सेइंग ऑन द ओटी, सर आप लोग करना ही, बच्चों से मत कराना. सो फ्लूइड इफ यू टॉक अबाउट, okay, fluid if you talk about, we have three basic categories of fluid. Yes, we have crystalloid, we will quickly see what is colloid also, and then we have blood and blood products. So we have blood and blood products. Let us try to understand. So when we talk about crystalloids, we have three categories of crystalloids. Remember, crystalloids are having the similar composition of the what? Plasma. Yeah, basically they are having the composition of plasma, so they're very comfortably given. Crystalloid can be hypotonic, they are hypotonic, and when we talk about hypotonic, it is 5% dextrose. बहुत important है, ये सारे questions आते हैं, 5% dextrose. Next is, it could be isotonic. When we talk about the isotonic fluids, we have ringer lactate, we have 0.9% NaCl, Yes, we have isolate. So isolate P, isolate M, you isolate G, बहुत सारे आते हैं ना, isolate P, isolate M, isolate G. Yes, then we have hypertonic. What are hypertonic? Let us see them also. Hypertonic. Yes, we also have one more, plasma light. Yes, plasma light. So hypertonic, if you talk about hypertonic, yes, we have 3 normal NaCl, we have 3 normal, that is what is known as hypertonic saline. Apart from that, और क्या होता है बच्चों, फटाफट बताओ, DNS का नाम सुना है, dextrose plus normal saline. Yes, that is what is DNS. Yes, okay. बच्चे, P for isolate pediatric. Yes, isolate pediatric. Yes, G for gastric, isolate gastric. Yes, and isolate M, I think isolate P, isolate M. Yeah, isolate M किसके लिए होता है? The M was for, I'll tell that. It just slipped off my mind. So हम जनरली अब isolate यूज नहीं करते हैं, पहले हम isolate यूज करते थे, अभी हम plasma light यूज करते हैं, आज के डेट में हम plasma light यूज करते हैं. Yes, next is, so DNS when we talk about, it's a hypertonic. Then the last is Darrow solution. What is so important in Darrow solution? Darrow solution is lactated saline. This is lactated saline, and remember, it is loaded with potassium. So maximum K plus concentration. Yeah, multi-electrolyte. It's basically isolate M. Yeah, I was saying that multi-electrolyte. So basically, आज की डेट में electrolytes ये isolate M ना देके, we are advising Amexin 10, Amexin 7%. So basically, that's a composition which is having that base of a crystalloid. Along with that, you have lot of electrolytes, and along with that, you have amino acids also added to that. So आज की डेट में वो ज़्यादा prefer किया जाता है. So multi-electrolyte, isolate से we have shifted to plasma lights, and then we have new composition. अब isolate बहुत ही कम जगह use करते हैं. Let us see. When we talk about colloids, I'll take this in detail. Blood में बस इतना याद रखना, the protocol of massive transfusion protocol. massive transfusion protocol, I'm just going to discuss the protocol. So when we talk about massive transfusion protocol, the one very important thing that we have to understand is whenever you have to transfuse more than 10 units of blood, yes or no, or you are planning to transfuse or you have transfused, but say don't give it like this. Rather you say give 1:1:1 FFP, packed RBCs, and the next is platelets. What is the utility of this? What is the utility of this? Because if you keep on adding the whole blood is devoid of component. There will be something which is known as dilutional coagulopathy, and this dilutional coagulopathy is the dangerous most aspect. Now, what is the concept of colloid? Let us quickly see. Since this is a revision, I know I'm skipping some topics because I want to compare lot of things here. Let us talk about this colloids. What are colloids, students? Colloids are heavy protein molecules. So they are synthetic heavy protein molecules. So what is the utility of synthetic heavy proteins? Actually, therefore, whenever you give these molecules, they are actually going to increase the what? Plasma osmolarity. So their main aim is to increase the osmolarity of the plasma, and once the osmolarity of the plasma is increased, what it is going to do? It is going to attract the water from the extravascular space into the intravascular space. This is what is. So from the extravascular space, the fluid will move into the intravascular space. So extravascular space से intravascular space में आती है. This is why, therefore, they are also known as plasma expanders. This is also why they are known as volume expanders. Students, most of you understand these concepts, but try to understand this is how the hypotension is corrected. Now you people have a notion that shock is equal to hypotension. Try to understand one very important. Awesome Shashmita bache, awesome bache. Why it is contraindicated in shock? Yes, why it is contraindicated in shock? One of your friend has already answered it. Try to understand shock के साथ problem क्या होती है? The shock is associated with the damaged endothelium. Yes or no? So there is damage to the endothelium, and because of this damaged endothelium, there is opening of gap junctions. Yes, opening of gap junctions. Yes, and what do? You attended my class. In an attempt to impress sister or impress your junior, you ordered for those special molecules, and ultimately what will happen? These molecules will leak out of the space, and ultimately the majority of the fraction will settle down in the extravascular space. So there will be, so therefore there is leak of colloid. There is leak of colloid, yes, into extravascular space. Remember, these are biosynthetic molecules and they don't interact with the cell. Their main aim is to their own presence. Like you must see, na? In parties you call celebrities. Why you call celebrities? To gather more and more crowd. Yes or no? So they're like celebrity. They say I'll not interact with anyone. If an ordinary normal saline leaks out, it will be absorbed by the cell. But ये colloids बाहर जाने के बाद वहीं के वहीं रहते हैं. They don't interact. Rather, they will do that celebrity status there. So they increase the osmolarity. So there is increase in osmolarity, but of extravascular space, and the reverse of what you were expecting happens here. Whatever fluid is there, this will also settle down out, and this is going to worsen the state of shock. Remember, in your body, any endothelium or any membrane requires at least 12 to 24 hours to settle down. So healing of endothelium requires 12 to 24 hours. Therefore they should be avoided. In this scenario. I hope this is clear to everyone. Let us quickly see what are the options that we have in colloids. Let us see what are the options that we have in colloids. When we talk about the options of colloids, what are the types of colloids that we are using? The first that we will be talking about is the recombinant human albumin. So recombinant human albumin, remember two important questions on them. This is available in two forms. Yes, 5% and 20%. 5% and 20%. Remember 5%, this question has also been asked. The increase in oncotic pressure, this is more than 20 mmHg, more than 20 mmHg, and this is more than 70 mmHg. If you talk about the volume expansion, students, remember this will cause one time volume expansion, this is going to cause 5 time volume expansion. Absolutely right, Shashmita Bache. This is really very costly. If you talk about the Indian players, yes, we have Reliance, Reliance हर जगह बच्चों के खिलौने बेचता है, Hamleys में भी है, सब जगह Reliance है. Wherever you go, Reliance is there. So Reliance वाला आता है 6200 का, yes or no? So if you talk about the Baxter, yes. If you talk about Intas, कोई भी 6,500 से कम नहीं आता है. That is why it is the drawback. It's the cost. This is also. Let us talk about some more important things. We have dextran. When we talk about dextran, what is the problem of dextran? It is the anaphylactic trait of the dextran which is a problem. Second, dextran is made by combination of leuconostoc meseldroids with streptococcus mutants that has been incubated in a sucrose solution for 30 days. So जैसे sucrose का component आ जाता है, the dextran which is available commercially in 30 kilodaltons, कुछ books कहती हैं 40 kilodaltons, 40D 30D दोनों form में available है, and 70 kilodaltons. So there are a lot of things. Try to understand what are the features. The first thing that you have to understand is volume expansion. But ज़्यादा नहीं, सिर्फ एक टाइम करता है. The second big problem is hyperglycemia, and that is why it is the least preferred colloid among surgeons. The third important thing is prolongs what time? Bleeding time. Prolongs bleeding time, and this is actually blessing in disguise. Do you know blessing in disguise? कहाँ पर dextran सबसे ज़्यादा use करते हैं? Yes. Try to understand. Where do we use? Remember, the use is in the flushing of microvascular anastomosis. Whatever microvascular anastomosis you are doing, you are flushing them with dextran. Ab example का है CABG. Like you are doing CABG, yes or no? So what is the biggest problem? The biggest problem is the thrombus which forms in these vessels, and this is going to cause a rejection of vascular anastomosis. That is why you flush it. And why you flush it? Because of a beautiful property, it prolongs the bleeding time. Is that clear or no? So next, so what is another problem? It interferes with blood group cross matching. So it interferes with blood group cross matching. This is again a problem. Yes. And I know, everyone knows that anaphylaxis is again a big problem. What else? There are two others. We have a heta starch, and then we have one more. We have hemexil. बच्चे 2-3 क्वेश्चन पूछे जा चुके हैं. From where is hemexil prepared? Yes, this is a polymer of degraded gelatin. Try to understand. It's a degraded gelatin polymer. Degraded gelatin polymer. Try to understand this. Let us quickly move forward, and we have just finished this. Yes, we have finished this, and now we are going to next topic. Quickly, let us see nutrition. So the next chapter that we are going to revise is nutrition. Non-stop entertainment. We are continuing. Yes, non-stop. We don't have that much of time. Yeah, we have to perform more in limited time. So when you talk about nutrition, the first question is, what are the modes of nutrition? Remember, again a statutory warning. This is a supplemental nutrition that we are going to discuss. So there are two modes of nutrition. One is your enteral, and one is your parenteral. Enteral versus parenteral, what is preferred? You know, I know, everyone knows, the planet knows that yes, this is preferred unless contraindication. Yes. Hi, Ripper. Hi, JTR Ripper. You're watching from Ethiopia. Actually, I'm very soon. I'm going to visit Nigeria. Yeah. So maybe as the COVID restrictions are over, I'm going to visit Nigeria. Yes, because I'm going to come to operate. So there's a hospital. I'll not disclose the name. So I have my association with some Gulf countries. So I'll be going to Gulf countries every alternate, you can say, months. So different Gulf countries, and there I will be going to teach laparoscopic surgery and do a surgery. So there will be cases. I'll be going for 1 week, and maybe in 1 week I could visit 2 countries and I operate. So I'll be very, maybe I come to Ethiopia, or if you want, you can come to my center to learn surgery when you become surgeon. Yes. So God bless you also. So meet very soon. So preferred unless contraindicated. Preferred, yes, unless contraindicated. Preferred unless contraindicated. No. Afghanistan, I'm not going to. Afghanistan, I'm not going to go. Yes. So enteral versus parenteral. When we talk about enteral, yes, this. What is the root? This is via alimentary tract. This is via alimentary tract. So this is via alimentary tract. So next year, once the COVID restrictions are over, yes, I'll be traveling a lot. Why? Because KLS Martin, I've been selected as the what you can say one of the key leaders in Asia. So they also will be holding like 8 to 10 conferences throughout the world. So I will be traveling to attend those conferences also. So जो those 2-2.5 साल बर्बाद किए ना, yes, I will be enjoying that. And the best thing is that wherever I go, Unacademy goes with me. Yes or no? So my kids are not going to miss anything. Yeah. So via alimentary tract, it is enteral. Then via venous route. This is parenteral. Now, when we talk about via venous route, try to understand one very interesting thing, that venous route can be 2 venous routes. Yes or no? So peripheral venous route. Yes. So peripheral venous route, and then we have the central venous route. Okay. Yeah. But for that, starting DNB, actually this is a big process. I've already started the work. So we have a lot of you can say formalities to be fulfilled to get the DNB. So once my new hospital gets the complete registration, etc., then I will apply for DNB, and then maybe I get 1 or 2 seats. So I'm trying. I will apply for 3 seats at least. लेकिन 2 या 1 तो मिलनी ही चाहिए, है ना? So you can come to my hospital to learn surgery also, and we will rock, है ना? मजा करेंगे, swag करेंगे दोनों लोग, हाँ? Yes. So peripheral venous route. बच्चे, what is the drawback? Of peripheral venous route? Peripheral venous route का सबसे बड़ा ड्रॉबैक होता है, the moment you started, after 6-7 hours or after 12 hours, maybe after 2 days, 3 days, patient will say, sir, there is lot of pain. And what is that? Thrombophlebitis. My ancestors are from Maharashtra, but I am not from Maharashtra. I have not been, I have not lived there, but my ancestors are from Maharashtra only. Yeah, they're from Nagpur, I think. Nagpur or Nasik, basically they are. So thrombophlebitis is actually the drawback. Then second thing is short life. So if you want to give it for a longer time, the problem arises here, because this is less than 7 days. So within 7 days the things will worsen, and then you will have to put the cannula again, and patient gets agitated. They say, doctor, I don't want this. Yes, love you Ram. Okay. So when we talk about the central venous route, this is preferred. Now I want to ask you, what is the vein which is preferred? Yes, this is infraclavicular subclavian vein. Infraclavicular subclavian vein is preferred over internal jugular vein. Now try to understand one very important thing. Let's say if I put the cannula here, do you know infraclavicular line insertion is a bit tough. Internal jugular vein is very easy. But what is the problem? If you put the line in the internal jugular, the line will be hanging like this. Yes or no? Line will be hanging like this, and try to understand the ergonomics. बच्चे infection नहीं, all these things forget everything. The problem है कि अगर patient को, if you have to keep the line for 10 days and the patient is having a line dangling like this, the ergonomics is destroyed. The first and the most important thing is the client satisfaction. Don't call them patients. बच्चे वो patient नहीं है, client है हमारे client की demand है. The client wants comfort, and that is why if you have the line firmly placed over this, you can say in the clavicular below infraclavicular approach, it is firmly placed over the chest wall. 10 दिन दो, 15 दिन दो, client खुश तभी पैसा देगा. Yes or no? If the client is happy, then only he'll pay. Remember, internal jugular vein is preferred. Important. You have to think, ultimately we all are businessmen. You've opted for a profession where business is the most important skill that you have to learn. बाद में learn करना बाकी कुछ. So if you see quacks, what is the difference between you and them? They are more patient, they are more engaging because they have learned the skill of dealing with the patient before मतलब learning how to treat them. उन्हें पता भी नहीं, but dealing आती है. That is what is. वो कहेंगे अरे नहीं, I will not do anything which is going to harm you. So try to understand. Important. What is important is internal jugular vein is preferred in case of trauma. Why? Because of the quicker access. Now try to understand. Very quickly we will see what are the contraindications. For the nutrition. Yeah, for contraindication for the nutrition. So contraindication for the enteral nutrition and contraindication for the parenteral nutrition. If you talk about the contraindication for the enteral nutrition, yes, what are they? Students, perforation is a contraindication. How will you give anything when the perforation is there? Yes or no? Then obstruction, yes. Severe vomiting, severe malabsorption and severe dehydration, severe vomiting, severe diarrhea and severe malabsorption. These are the places where you will absolutely avoid enteral nutrition. Apart from that, any patient with peritonitis, any patient with sepsis, बच्चे not diarrhea. शश्मिता बच्चे इस चीज को समझो. This is a trap. You get a question here and the option says what are the contraindications? Vomiting, severe malabsorption, perforation, sepsis. Try to understand. What is not a contraindication, students? Vomiting is the answer. You people readily mark sepsis. Severe vomiting, severe diarrhea. This is what. Now let us talk about the parenteral nutrition. Answer is diabetes mellitus. The second thing is, tell me, congestive heart failure, yes, and COPD. So congestive heart failure, COPD. What else? Students, sepsis. Do you know that sepsis is a relative contraindication for enteral nutrition? Sepsis is absolute contraindication. Sepsis is absolute. Can you tell me why? Why sepsis is contraindicated? Why parenteral nutrition is contraindicated? Try to understand, students. If you talk about parenteral nutrition, समझे कि नहीं? इसका 70%, the 70% content, 72%, 80% content is carb, and carbohydrate is going to increase the blood sugar levels. Is that clear or no? And increased blood sugar level is going to decrease the immunity. Is that clear or no? And not only it is going to decrease immunity, it is also going to decrease the inflammation. Bachche, anything which is going to mask inflammation, it is going to mask immunity, it is going to act like steroid in sepsis. Yes or no? So bachche, it is going to increase the translocation of bacteria from the gut also. Yes, and that is also going to cause peritonitis. So nahi dete, bilkul hi nahi dete. Next is, apart from that, you have hypokalemia, hypomagnesemia. चलो magnesemia तो relative है. Hypophosphatemia, metabolic acidosis, metabolic acidosis and alkalosis. So metabolic acidosis, metabolic alkalosis. Let us quickly understand some important points about parenteral nutrition also. Quickly, we'll give only 15-20 minutes, 15 minutes to this chapter. Take my words, these 15 minutes will change the game, because definitely you get questions on these topics. So when we talk about the parenteral nutrition, what are the types of parenteral nutrition? Types, if you talk on the basis of root, yes or no? We have two types of parenteral nutrition. One is TPN, one is PPN. What do you mean by PPN versus TPN? PPN is not partial, it is peripheral. It is peripheral parenteral nutrition, and this is total parenteral nutrition. How do you decide? Bache, if you talk about the root for TPN is central venous root, and the root for peripheral parenteral nutrition is your peripheral venous. So peripheral venous root. Now you have to understand that there is no difference in composition. बच्चे रिद्धिमा, try to understand. पिक नहीं होता ये. Pick, this is not pick. What is pick? Peripherally inserted central catheter. Basically pick में आप क्या करते हो, उस catheter को central vein में लेके जाते हो. And pick is actually the most absurd form of what? Delivering the nutrition into the central vein. Try to understand. Pick is inserted peripherally, but actually pick is suitable for the TPN also, because ultimately you are going to go into a central vein. Is that clear or no? So thrombophlebitis का जो chance होता है वो कम हो जाता है, but pick is actually permanently going to destroy a vein. So हम pick नहीं insert करते, हम central venous axis ले लेते हैं या फिर peripheral vein पे rely करते हैं. So let us try to understand that if you want to give anything by the peripheral venous route, yes or no, it has to be more diluted in composition, because if it is not diluted in composition, it's going to result in more severe thrombophlebitis. So in order to make it adjustable to the peripheral veins, the density of this is less. So density, if you talk about density, but this is low. So low density, low means less than 650 milliosmoles, per liter. और यहाँ पर they have high density. What do you mean by high? More than 950 milliosmoles per liter. Is this point clear or no? ये तो हो गया root के हिसाब से. Then the another classification is on the basis of composition. On the basis of composition, there are three main ingredients: carbs, lipids, and proteins. It is of two types. Either it could be 2-in-1 or it could be 3-in-1. So 2-in-1 versus 3-in-1. Let us try to understand this thing. 2-in-1 versus 3-in-1. Let us see. Bache, carbs, lipids, and proteins. So carb, lipids, and proteins, it's simple. So this is 70% is carb in this, 20% by volume is lipid in this, and 10% is protein in this. Here 70 to 80% by volume is carb. There is nothing known as lipids. 10 to 20% is protein. Let anyone say anything. Bache, let anyone say anything. This is the only composition, because people teach, I use. If you talk about my hospital, I consume roughly around 100 TPN bags per month, at least 100 TPN, because I am actually fond of parenteral nutrition, because we believe that yes, a sick patient before surgery or post surgery, parenteral nutrition can improve the status. Now 3-in-1 and 2-in-1 is preferred, but try to understand. 3-in-1 is for countries like India. 2-in-1 is for countries like US. What is the difference? The difference is this word is run by handful of economists. But all these insurance companies, they get a hefty bill. Why? Because lipid is actually going to delay the hospital stay. And if the hospital stay is prolonged, बच्चे हमारे यहाँ कुछ नहीं होता ना. In our medical colleges, you see there are patients who are staying there, who are staying for what? 6 months, 6 years. I still remember in my medical college, North Bengal Medical College. There was a patient who was there from 7 years. From 7 years. वो दिक्कत क्या है? Bed मिला है, खाने को patient खाने को खाना मिलता है. Everything is there. Patient was there, but there it is not. Yeah, there is not. No. What is the problem in developed countries? The medical bill will increase. Suppose if a patient is on 2-in-1 TP, 3-in-1 TPN, and if average hospital stay is prolonged by 5 days, so if there are 1,000 people at a time, कितना ज़्यादा bill बढ़ जाएगा? That is why they said, why do you require lipids? The answer was for assimilating fat-soluble vitamins, especially vitamin D, vitamin A. They say that our patients are not that malnourished. So why to add lipids? Go for carbs and proteins and that will work. And that is why 2-in-1 rule came into role. So ये है 2-in-1 और 3-in-1 की कहानी. Let us quickly talk about the other things. Let us quickly. नहीं, अभी I am not in Ayushman. Now I have owned my own hospitals. I have 2 hospitals right now. One is in Palam, Highland Care Hospital Palam, and one is opening very soon, next month. It is in Dwarka. So let us move forward. It's all with your blessings that I have done so great. When you talk about carbs, lipids and proteins, apart from that, you have other components also, others. बच्चे मेरे जैसे लोग ना लाला की नौकरी नहीं कर पाते ज़्यादा दिन तक, yeah. So I did not work. I am a boss of my own things. So I'll just enjoy that thing, yeah. The best thing about Unacademy also, I like this, that they have left everything on me. They ask me, sir, you decide what to do, how to teach, and this, again, I'm enjoying that privilege here. So apart from this, since you're giving 70% of carbohydrate, you need some lipids also. Yes, so you need some insulin also. So insulin, yes. We have insulin. We have PPIs, yes. We have sterile water to dilute it. And along with that, we have essential vitamins and minerals. So we have essential vitamins and minerals. Yes, so these are very, very, very important things that you should be having. Let us try to understand few more very important things. Very, 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 very important. You know, the best thing about Unacademy, like, try to understand who will arrange for this much, you can say, big session. Yeah, who is, Unacademy is a platform where they have left that level of selfishness down. They have raised their level above that, and they're giving so much of you can say, free education to all the sectors. So I just feel like yes, giving them a big salute. Anyways, let us come back. Now, before moving forward into the complication, etc., I am going to discuss with you the protocol. Whenever you have a question in your brain, should I start yes, supplemental nutrition? When you want to start a supplemental nutrition, the first question you will have to ask, should I have to start this supplemental nutrition? Point number 1. Answer could be, what is the duration of lack of feed? So duration of lack of feed. What do you mean by duration of lack of feed? बच्चे कितने दिन से खाना नहीं खाया? That is what. For how long, how many days the patient hasn't received the food. So duration of lack of feed, or you can say, or anticipated duration of lack of feed. Anticipated. What do you mean by anticipated lack of feed? Suppose you are going to do a surgery after which the patient will not be able to have anything. So this is very important. So if there is a lack of feed for less than 7 days, answer is no, you don't have to start. If the lack of feed is for more than equal to 7 days, boss, this is a big time. You cannot manage only with fluids. You have to start the enteral nutrition or parenteral nutrition. Now, when we talk about which route is indicated, now we have studied one thing, that unless contraindicated, you have to go for enteral nutrition. सबसे पहले हम यही पूछ लेते हैं ना कि is enteral nutrition contraindicated? Because if the answer is yes, you will start what nutrition, students? Parenteral nutrition. Is that clear or no? And if it is not contraindicated, not contraindicated, then you will have to start what nutrition? Enteral nutrition. Are you getting this? This is very simple. अभी when you want to start the enteral nutrition versus parenteral nutrition, there are again choices. You want to start parenteral nutrition, the next thing you will ask to yourself, the duration of support required. The duration of support required. So how long do you want to give the support? Yes. Answer is no, sir. I want to give only 1 or 2 bags of TPN. That is sufficient. So that means you require a short support of less than 1 week. Yes or no? So less than 1 week support. If you require a less than 1 week support, there is no point endangering the life of the patient by inserting a central access. So in that case, bachcho, you can go for a what type of route? PPN. Excellent, excellent. So there you will go for PPN. If you want a long duration support, more than 1 week, you will go for TPN. TPN. Is that clear? So when we talk about the enteral nutrition, but again the duration of support is very important. Duration of support. When we talk about the duration of support, there are 2 important questions that come in our mind. Sir, less than equal to 4 weeks, less than equal to 4 weeks, or more than 4 weeks. So less than equal to 4 weeks or more than 4 weeks. When we talk about less than 4 weeks, yes, we have 2 routes. We have Ryle's tube feeding or we have NJ feeding. So here you again have to ask how good the stomach is working. Gastric emptying. Is the gastric emptying good? If it is good, bache, there is nothing better than the stomach as a reservoir. So go for RT feed. RT feed, Ryle's tube feed. Yes, the advantage is there will be no dumping. Yes or no? It's easy to insert. Patient nikal bhi deta to change kar doge. Yes. So if it is poor, then what to go for? You have to go for NJ feed, nasojejunal feed. The big drawback of this feed is dumping. But the problem is it will prevent if you give a patient with poor gastric emptying, if you give RT feed, there will be what? Aspiration pneumonitis, and this is what is known as Mendelssohn syndrome. I hope most of you know Mendelssohn syndrome, aspiration pneumonitis. So you don't give that. When it is for more than 4, dumping syndrome is a common complication with the NJ feed. Ryle's tube feeding, Mendelssohn syndrome because of aspiration. Are you getting these things? Aspiration pneumonitis is going to happen. Similarly, if you want it for 4 weeks, you cannot put a Ryle's tube there. So there you have 2 options, again depending upon the gastric emptying. If the gastric emptying is good, you have nothing better than feeding gastrostomy. Feeding gastrostomy. So you go for a laparoscopic or you go for an endoscopic peg insertion. Yes or no? So either this. If it is poor, then you go for feeding jejunostomy. If you would have attended my classes, I always show how we do a laparoscopic feeding jejunostomy, how we do a laparoscopic feeding gastrostomy, and this is actually the best way to manage a patient's nutrition for a very long phase. So this is what is about nutrition. Let us quickly discuss 2-3 important points on complications of parenteral nutrition. So complications of parenteral nutrition. When we talk about the concept of complication, why not RT more than 4 weeks? बच्चे समझो इसको समझो. देखो, if you insert a Ryle's tube for more than 4 weeks, yes or no? More than 4 weeks. Ryle's tube is actually a foreign body. It is going to excoriate and damage all the nasal epithelium and nasal mucosa. Yes, the pharyngeal mucosa and then the esophageal mucosa. Also, what will happen? There will be development of some fibrotic tissue. There will be development of some fibrotic tissue over this, and this tube might get adhered to that fibrotic tissue and engulf. So, अब क्या होगा? When you try to pull it out, yes or no? It will not come. It will not come. Yes or no? So that is what is the problem. So these are the challenges that we have. So basically, again, बच्चे आपको client के बारे में सोचना है. You have to think about client. Client is more important. You cannot put client in discomfort. A patient, if you want to put a damage on the client, put the damage on his pocket, but not on his health. This is the thing which the client will always appreciate. कि ठीक है, पैसा ले लो जितना भी लेना. डॉक्टर साहब इलाज नंबर 1 चाहिए मेरे को. Yes or no? This is what happens. Yeah, that is what. So peg को तो peg for more than 4 weeks नहीं बच्चे, नहीं. जिया बच्चे, अच्छा, try to understand. I had a patient of multiple sclerosis, ठीक है. अब multiple sclerosis MSc का patient है. Recently I did PEG for that patient. Now tell me, over the time he will have bulbar. Hi, hi. Okay, okay. I think it's sorted out. Yeah. Just a minute. Huh? Okay. So let us just start. Huh? Let us just start. Okay. So clear. So I was saying the patient had bulbar palsy. Yeah, the patient had bulbar palsy, and the patient couldn't go for what proper feeding. So I had to do this. I had done this surgery for that patient. ठीक है? Okay, okay, it's okay. Yes, it's okay. Audio video clear. Audio video clear to all. Yes, yes, yes. Anyways, let us move forward. I was talking about complications of parenteral nutrition. Hyperglycemia is the most common. The second most common is fluid overload. What is the criteria for fluid overload? What is the criteria for fluid overload? The criteria is weight gain. Weight gain more than 1 kg per day. Weight gain more than 1 kg per day. The third most common is electrolyte imbalance. Electrolyte imbalance. When we talk about electrolyte imbalance, yes, this is hypo more frequently seen than hyper. Point number one. The second important thing is this is the most common cause of death. This is the most common cause of death in long-term TPN therapy. So long-term TPN therapy, very good, very good. So long-term TPN therapy, the cause of death is your electrolyte imbalance. Apart from this, you also have a very important complication arising from that, that is refeeding syndrome. So rare but seen. So rare but seen. Why rare nowadays? Why rare nowadays? Because nowadays we are aware of this thing. So it's a refeeding syndrome. What is refeeding syndrome? What is refeeding syndrome? The most important thing. Audio video clear, bachcho? Is it clear? Everything is clear, na? Yes. Okay. So when you talk about refeeding syndrome, this is nothing but metabolic alteration. Metabolic alteration, yes, or derangement. So metabolic derangement, which is seen post what, students? Post initiation of parenteral nutrition. The most important defect that you get to see, is it is hypokalemia, hypomagnesemia, hypocalcemia, and hypophosphatemia. Amongst them, it is hypophosphatemia which is the most important. Try to understand who is at risk of refeeding syndrome. Refeeding syndrome doesn't develop in all, but in what group of condition it is common. So remember, refeeding syndrome is seen in patients who are alcoholic. So alcoholic withdrawal, yes, alcoholic. Then chronic illness, patient with chronic illness. So alcoholic हो सकते हैं, chronic illness हो सकती है. Then patients with malnutrition, and then yes, severe anemia. They are the patients where yes, this is going to happen. बच्चे diabetic में नहीं, but uncontrolled diabetes. First of all, diabetes, why will you give TPN? Abhineet, try to understand why will you give TPN to a patient who is diabetic? तो नहीं देते ना उसमें. Yes. Very quickly we will revise the wounds The next chapter that we are going to revise is wounds. So the next chapter is wounds, because there is going to be one question asked from this. So next question that we are going to discuss is wounds. When we talk about wounds, the first thing that is very common is the classification of the wound. Yes or no? So we have class 1 wounds. What are the class 1 wounds also known as? The class 1 wounds are also known as your clean wounds. Yes or no? Clean wounds. Yes. Clean wounds, if you talk about, they are the wounds which are associated with surface surgeries. So there is no entry into GIT, GUT, respiratory tract. Students, if I ask to you that you are excising a lipoma, excision of lipoma from the surface of the body, mastectomy, yes or no? So anywhere where you're not, like amputation, or you can say if you are doing amputation for a malignancy of the limb, again it's a clean wound. Yes or no? So try to understand, you don't incorporate any place which is hollow viscous. So GIT, GUT, respiratory tract, there is no contamination. There is difference between contamination and infection. Contamination is presence of bacteria. Then we have proliferation, where the bacteria that has contaminated with proliferate also, and then that proliferated bacteria will produce symptoms. That is what is infection. Yes, Neeraj, thyroidectomy is also a clean wound, but hernia surgery, inguinal hernia, is not a clean wound. Why? Because you are dealing with peritoneum. Are you getting this or no? So class 1, despite that they are not having any of these things, there is 1 to 5% risk of SSI. 1 to 5% risk of SSI. Students, 1 to 3% is also right, because many books are writing 1 to 3, some books write 1 to 5. Anyways, we can take it 1 to 5 as a broader range. Then we have class 2 wounds. What are class 2 wounds, students? Class 2 wounds are defined as clean contaminated. Clean contaminated. When you talk about clean contaminated, बच्चे C section कैसे हो सकता है नीरज? अच्छा, you are giving example of this clean contaminated, yeah? अच्छा, you are asking C section कहाँ पर करते हो? देखो, you open up the abdominal cavity ना. If you are opening up the abdominal cavity, yes, you are handling the viscera. So it's a clean contaminated wounds. So genitourinary tract आतो के ना GUT, you're handling GUT na, genitourinary tract. So C-section is basically it's a GUT. It's a GUT, but the access is via the abdominal. Yeah. So clean contaminated wound. So there is entry into GIT, GUT, respiratory tract, GIT, GUT, respiratory tract without spillage. But C-section is not class 1. Yes, without spillage. Is that clear or no? Remember, either without spillage or controlled spillage. Try to understand either without or controlled. What do you mean by controlled spillage? Yes, suppose this is a gallbladder. Yes or no? This is a gallbladder. Now, operating on this gallbladder is a class 2 surgery. Laparoscopic cholecystectomy is a class 2. Why? Because this is a part of GIT. Yes. Doing hemicolectomy is a class 2. Yes or no? Radical cystectomy is a class 2. Now, when you were doing cholecystectomy, you found that it was empyema gallbladder. And if it is empyema gallbladder, what is the next thing that you will not get that fundal traction? So you require that what? You require that aspiration needle. So you'll definitely get that aspiration needle. You'll get that aspiration needle and it will go inside. There may be a drop or two which might spill out. What is that? That will be a class 2, because that is under your control. The spillage is under your control. What you will do after, just as soon as 1 or 2 drops fall, you can just suck that out. If there is some bile which has fallen down, you can suck that out. That is a clean contaminated wound. Is that clear? So controlledly, remember 2 to 9% risk of SSI. So 2 to 9% risk of SSI. Are you getting this? So try to understand the hairline difference between this controlled spillage. So without spillage or controlled spillage. Yeah. The next is contaminated wounds. Contaminated wounds. When we talk about IPOM is class 1 because we don't open the peritoneal cavity. Acha, tell me, IPOM क्या होता है? Varun, try to understand. What is IPOM? देखो, just see. If you talk about IPOM, I'll just show you one thing so that you understand the concept बच्चे. IPOM में हम सबसे पहली चीज जो करते हैं वो क्या करते हैं? We are going inside. So if you are going inside the abdomen, you cut through the peritoneal cavity and then you go inside. Just see this varice is going inside. Yes or no? And then what you are doing? What are you doing? Are you not handling the bowel, bache? Tell me. Are you not handling the bowel? You are cutting through the bowel. You are handling the bowel. This is what? This is mesentery. This is omentum and mesentery. So you're handling. You're inside the peritoneal cavity. Are you getting this? So whenever you are inside the peritoneal cavity, there is always an external you can say risk of external microbes entering into that. So समझे कि नहीं? तो IPOM तो बच्चे होगा ही होगा. So IPOM तो contaminated clean contaminated में आएगा. So contaminated wound. This is having a risk. This is class 3. This is class 3. And remember the risk of infection is 3 to 13%. Appendicectomy again it will be a class 3, class 2. कोई भी part GIT, GUT, respiratory tract का है, that will be a class 2 surgery. Is that clear or no? If you are dealing with peritoneal cavity or peritoneum, it's a class 2. बच्चे appendicectomy if done laparoscopic is class 2. If infected or perforated, of course perforated to class 3. Is that clear? Infected you cannot tell. If it is perforated, then only. Yes or no? Space of Bogros, if you talk about. But space of Bogros, if you are exploring, they could try to understand. When you, I'll tell you about everything. मैं बता दूँगा आपको. So when you are talking about contaminated wound, what is contaminated wound? This is entry into GIT, GUT, respiratory tract with spillage. With gross spillage. Is that clear? No? With gross spillage. Okay. With gross spillage. Now try to understand. The next very important thing is if there is any surgery where there is gross breach of asepsis. Now what do you mean by the concept of gross breach of asepsis? Where can you expect gross breach of asepsis? Can you tell me? If you do emergency room surgeries, yes or no? Yes, if you do hydrocele in emergency room, what is that? Gross breach of asepsis. You may be using anything which is sterile, but since you are doing it in what? A place which is not a sterile zone, that is what is. You know, so today the most important thing of a sterile zone is the laminar flow. So laminar flow is not there. So laminar flow is something which is helping the bacteria move out. It will, if you see a laminar, you know, why OTs are very costly? Why OTs are very costly? Because of this only. Today, if you are getting a modular OT done, a good modular OT will cost you 25 to 30,000 just for the paneling and walling, wall and roof and duct system. Why it will cost that much? You know, the answer is, forget about light. I'm not talking about light, etc. The answer is the cooling system, the laminar flow system. Even if there is a hair follicle, that will be sucked out of that. So infection contamination को control करने के लिए we're spending that much of amount. So gross breach of asepsis, example for this is ER room open cardiac massage for asystole patients. Yeah, so open cardiac massage. बच्चे herniorrhaphy, आप herniorrhaphy करो या herniottomy करो and you do a repair. If you are handling the peritoneal cavity, you are actually dealing with at least a clean contaminated wound. Now when you talk about space of Bogota, Abhijit, are you talking about space of Bogros or space of Bogota? Space of Bogros is a space between the peritoneal cavity and the fascia transversalis. किसके बारे में बात कर रहे हो? I'll tell. देखो, अगर आप space of Bogros के बारे में बात कर रहे हो, so try to understand how do you access that. So fresh accidental wounds are also considered they are also considered was class 3 wounds. Like let me tell you about the space of Bogros. देखो बच्चे, यही तो है space of Bogros. तो उसको खोला कैसे? First of all, gone inside the peritoneal cavity. Then only I was able to open the space of Bogros. Now I'm doing the surgery here, hernia surgery there. So I'm not cut open the lumen of a bowel, but this is a peritoneal cavity, boss. Like if you even say that I am going for TEP, like this is a TAPP. Yes, if you say I will go for TEP, when you are handling this, many a times there is during adhesiolysis of the bowel, during adhesiolysis of this peritoneum, there are buttonhole tears in this peritoneum. Automatically it will be a what? Class 2 wound at least. So बच्चे कहीं भी peritoneal cavity आती, you will mark class 2, not class 1. Are you getting? So this is contaminated. Then contaminated. Next. So try to understand what is the fourth. That is the dirty wounds. Dirty wounds. When you talk about dirty wounds, this is class 4. This is class 4. Now try to understand what is class 4. Grossly infected wounds. So grossly infected wounds. Point number 1. Grossly infected wounds. The second very important thing is, what are they? Which is spontaneous viscous perforation. Like, yeah, Shushmita, you were saying, you were answering or discussing. Acha, laparoscopically, if you are operating on appendix and you see a perforated appendix, so spontaneous perforations of any organ, spontaneous perforation of viscous, this is what is considered as dirty wounds. Is that clear? Like appendicular perforation, patients will always have peritonitis. So it's a dirty wound now. It's a dirty wound. Okay, so Sushmita, try to understand perforated viscous, like perforated appendix, peptic perforation, appendicular perforation, colonic perforation, enteric perforation, jitne bhi perforations hote hain, they're all class 4 wounds. They have variable risk of SSI. Variable SSI risk. Is that clear? Some books say 13 to 30%. Some books say 30 to 27%. I'm not writing that. Remember, this is what. Next is, when we talk about the wounds, you have two important scores. So when we talk about wounds, you have two important scores for the wounds. Scores. The first score that you have in wounds, is the Southampton score. So Southampton's score. This is very important. Southampton score. And then next is you have the asepsis score. Asepsis score. Why are you writing? Sorry, bache. In my class, always be casual. Huh? I'm your dada. I'm not your teacher. Huh? So you can answer. You can talk. Do everything. You should be comfortable. Yeah. Next is Southampton score. If you talk about grade 1, बच्चे क्या होता है grade 1 Southampton's? There is only bruise. What do you mean by bruise? The patient will come up with a wound which is having this typical what? Reddishness. Yeah, this is what is Southampton's grade 1. What is type 2? It is bruise plus features of inflammation. Yes or no? Then we have class 3 wounds. Category 3, grade 3. What is grade 3? Clear discharge. When we talk about clear discharge, it is further divided into 3A, B and C. 3A is what? It's a serous discharge. 3B is a sanguineous discharge. But bed sore is totally different. I will discuss that. I will discuss bed sores, don't worry. 3C is a serosanguinous discharge. Yes or no? Class 4 or grade 4. What is grade 4, students? Purulent discharge. And what is grade 5 of a wound? Yes, this is abscess or necrotizing fasciitis. So abscess or necrotizing fasciitis. All these are very important. Okay, let us try to understand. When we talk about asepsis is a very atypical type of scoring system where you have point based calibration. So 1 to 10, 1 to 5 like this, 1 to 10, 1 to 5 like this. Yeah. So don't remember how to score. Remember the parameters, the points which are there in asepsis. Let us try to understand what are the parameters. Let us see them. Let us try to understand them. Okay. A stands for additional treatment required. So additional treatment required. So like suppose there was a patient who was admitted and the patient required what? The patient required debridement, the patient required broad spectrum extra antibiotics. So yes, this is what. Or maybe there was collection for which the patient went for incision and drain. So incision and drainage, debridement, incision and drainage, debridement, or you can say antibiotics, broad spectrum antibiotics, etc. Unconventional broad spectrum antibiotics were given. So this is 1 to 10 scoring system. Yes. Peritonitis, नहीं बच्चे वेयर कौन कंफ्यूज शिवम बेटा आप कहाँ परेशान हो कहाँ कंफ्यूज हो पेरिटोनाइटिस तो होगा ही ना विस्कस परफोरेशन होगा सो दैट विल बी क्लास 4 दैट विल बी ए परफोरेशन आई एम टॉकिंग अबाउट द वुंड स्कोरिंग साउथ हैम्पटन्स की स्कोरिंग से कंफ्यूज मत करना ग्रेड 4 को जैसे डिस्चार्ज वाले पॉइंट सो ए इज फॉर एडिशनल ट्रीटमेंट रिक्वायर्ड देन व्हाट इज दिस एस स्टैंड्स फॉर या serous discharge yes. And what does this E stands for? Erythema. Yes or no? So erythema. What does this P stands for? Purulent discharge. Yes or no? Then what does this S again stands for? Separation of skin. You know, whenever like someone has written also, yeah, Neeraj has written wound break. So try to understand whenever there is infection of the wound will what? Dehisce off and there will be gaping of wound. We typically use the word gaping of the wound. Remember, separation of the skin. Then I, isolation of bacteria. Yes or no? And then one more I. What is that, students? Yes. What is S? Stay prolonged. So stay prolonged by more than yes 14 days. So these are the parameters. Like there was a question which was asked in last to last year. The question was which is not a parameter और उसमें question में लिखा था there was a word written induration. So students, induration is not a part. Yes, I'll have a glass of water because I'm very thirsty, speaking for a very long time and that too in a continuous fashion. Just give me a minute. Okay. Next is, so this was about wounds. Yeah. Next, let us talk about the SSI. What is SSI? Students, surgical site infection. Again, students, this is very important. When we talk about surgical site infection, the first thing that you want is whether the infection has occurred along the incision line or along the wound. Yes or no? So it could be incisional. SSI. Or the second thing is yeah. So it could be incisional SSI. Where have I taken your class? Sushmita, where have I taught you? Huh? Okay, on this platform or any other platform. Yeah. So incisional, or the second one is the organ SSI. So when we talk about incisional versus organ SSI, yes, incisional, but gangrene grade 4, grossly contaminated, grossly infected wound. Gangrene तो उसी में आ गया ना बच्चे, gangrene grade 4 में. Incisional is again further divided into superficial or deep incisional. Yes, superficial and deep incision. So great. So are you taking my Sushmita बच्चे, are you taking my these special classes etc.? They are also very, so बहुत सारी चीजें पढ़ाता हूँ मैं. I teach everything there. So you can always join the special classes and I teach a lot of things there. When we talk about superficial versus deep, what is so important in that? Superficial incisional SSIs, yes, they involve, SSI along the skin and subcutaneous tissues. SSI along the skin and subcutaneous tissue within 30 days of surgery. Yes or no? Within 30 days. 30 days of surgery. So within 30 days of surgery, this is what. अच्छा शिवम नहीं समझ में class 3 and 4. I'll explain it to you. Don't worry. First try to understand this. After this I'll explain. So if you talk about the incision, there are layers of the incision: skin, subcutaneous tissue, superficial. Deep incisional, SSI along the incision line. SSI along the incision line. Remember, other than skin and subcutaneous tissue. Other than skin and subcutaneous tissues. The time duration is within 30 days of surgery. So within 30 days of surgery, or within 1 year of implants. So within 1 year of implants, or within 30 days of surgery. This is what is very important. Try to understand. I'll explain them. What is organ SSI? Organ SSI is SSI along the anatomy manipulated. SSI along the anatomy manipulated during surgery. So along the anatomy manipulated during surgery. Yes. Other than incision. Yes. Remember, within 1 year of implants of 30 days of surgery. Now I'll discuss a lot of cases here so that you don't get confused. Suppose scenario number 1, I'm going to discuss them. Case 1, yes. So post laparotomy, yeah, patient underwent laparotomy. There is pus coming out from skin and subcutaneous tissue within 15 days of surgery. Tell me, is it SSI? Come on, tell me. Is it SSI? Answer is, it is involving the skin and the subcutaneous tissue. Yes, it is SSI. Why? Because it is occurring within 15 days and this will be superficial SSI. Clear? Same question. Post laparotomy. After 20 days, there is myonecrosis of the incision. Myonecrosis along the incision. Is this SSI? Tell me, is this SSI? Answer is, sir, this is also SSI. Because time bhi hai and the place also is the same. So this will be a deep incisional SSI. Deep incisional SSI. Are you getting? Now suppose again the third scenario is post lap cholecystectomy. Patient presenting to you on day 4 with fever. Yes, you went for ultrasound and ultrasound shows 12 centimeter biloma under the right diaphragm, under right hemidiaphragm. Now tell me, is this SSI, and if, then what? बच्चे day 4 में biloma under the right diaphragm or means collection of bile under the right diaphragm. Answer is yes, it is SSI. This is organ SSI because during surgery the anatomy around the gallbladder and the liver was manipulated. Yes or no? Whenever you take out the gallbladder, you keep it on the liver. Yes or no? So suppose there could be a possibility why this biloma happened. There is not a leak, but still maybe the gallbladder would have perforated and the bile collected there. You did not do any suction irrigation, and that 15 to 12, 20 cc or 30 cc of bile stayed there and collected there as an encysted or loculated cavity. That is what is. So, bache, try to understand. This is SSI, and this is because of what? Manipulation around the organ. So this is an organ SSI. Now Shivam, you were asking, sir, grade 3, grade 4 नहीं समझ में किसका wound का classification ना? Try to understand. Suppose बच्चे, if you are doing any surgery where there is a gross spillage, like suppose if you are doing right hemicolectomy and there was slippage of the clamp of the bowel and all the fecal matter came into the abdominal cavity now. Yes or no? So what is that? That is a contaminated wound now. Is that clear? You will do a lot of irrigation, but this will be a contaminated. Suppose radical cystectomy. Doing a radical cystectomy, that means removal of or resection of the bladder. It's a class 2 wound. But during that, you have to clamp the ureters. And suppose there was spillage of urine in the abdominal cavity. Again, this is a class 3 wound now. What is a class 4? Non-healing chronic wounds. What are chronic wounds? More than 3 months old wounds. Grossly infected and dirty wounds. They are again your class 4 wounds. Any patient who is having spontaneous viscous perforation, like peptic perforation, yes, all those things. So they are actually involved into that class 4 category of wounds. I hope this part is clear to everyone, students. Yes or no? Yes. Shall I move forward? So with this, I finished wounds and SSI also. Very quickly, I'll discuss one more topic very quickly, that is abdominal compartment syndrome also. So abdominal compartment syndrome. I'll just discuss the criteria and move forward. When we talk about abdominal compartment syndrome, this is defined as what is the criteria? What is the criteria of abdominal compartment syndrome? The criteria is intra-abdominal pressure. Intra-abdominal pressure. There is more than, the pressure is more than 20 mmHg. Students, pressure is not that important. What is important is the organ failure. So intra-abdominal pressure more than 20 mmHg. Along with that, new onset organ failure. New onset organ failure. Is that clear? So new onset organ failure with intra-abdominal pressure more than 20 mmHg plus minus intra-abdominal perfusion. So abdominal perfusion pressure less than 60 mmHg. Yes or no? So this is what is. Very good. There's a circulatory failure now. So organ failure is the most important aspect of this. But it has been seen that organ failure can occur at pressures lower than 20 also. That is also included in abdominal compartment syndrome. Try to understand what is the normal intra-abdominal pressure. The normal intra-abdominal pressure is kitna hota bachcho? It is 5 to 7 mmHg. So if there is only increase in the pressure, we don't call it abdominal compartment syndrome. We call it intra-abdominal hypertension. So let us quickly talk about this concept of intra-abdominal hypertension. Let us talk about this intra-abdominal hypertension. Yes, IAH. When we talk about intra-abdominal hypertension, the criteria for intra-abdominal hypertension is, remember, intra-abdominal pressure more than 12 mmHg. If you want grading, I can give you grading also of both. Let's say grading of intra-abdominal hypertension, grade 1 is 12 to 15 mmHg. Grade 2 is more than 15 up to 20 mmHg. Grade 3 is more than 20 up to 25 mmHg. Grade 4 is more than 25 mmHg. If you talk about the grading of abdominal compartment syndrome, yes, yeah, it is organ failure is must. So grade 1 is pressure, pressure. If you talk about intra-abdominal pressure, so intra-abdominal pressure more than 10 up to 15 mmHg. 10 to 15 mmHg plus organ failure. This is grade 1. Grade 2, more than 15 up to 25 mmHg plus organ failure, grade 2. Can you see now, even if the pressure is less than 20, organ failure occurs, it's a abdominal compartment syndrome. Grade 3, more than 25 mmHg plus organ failure. And what is grade 4, students? More than 25 up to 35, more than 35 mmHg plus organ failure. Done. Very quickly we will see, let's say, abdominal compartment syndrome are of 3 types. I'll just quickly discuss with this with you. Abdominal compartment syndrome is of 3 types. It is primary. When the defect is in abdomen, yes. So the original defect is in abdomen. What could be the reasons of this? Can you tell me? Bache, trauma. So a hemoperitoneum can cause. Yes or no? Tumor. So trauma, tumor. Yes. So trauma, tumor. These are primary. You can say post cardiopulmonary bypass. So post cardiopulmonary. Sorry. This is not the you can say type primary. This is a secondary. So secondary. When you talk about secondary, yes, we have due to fluid resuscitation. So fluid overload. Yes. Again. So portal hypertension. Portal hypertension will be a primary. Portal hypertension. Again, bache, foreign body inside the abdomen. Is going to be what? Secondary. Burns, secondary. Yes or no? Post cardiopulmonary bypass. This is what is. So primary, secondary, and the third one is a recurrent. Let us quickly see what is recurrent. It may be primary, it may be secondary. If it has shown the recurrence, that is what is recurrent. Next is, let us quickly see the management part. So confirmation of the diagnosis. So how do you confirm the diagnosis? So confirmation. Answer is, there is clinical suspicion. How this clinical suspicion happens? Oliguria, respiratory distress, abdominal distension, pain in abdomen. And along with that, confirmation is done with what? Urine. So urinary bladder pressure measurement. So urinary bladder pressure measurement is actually the gold standard. So urinary bladder pressure measurement is the gold standard. How you do this? I hope you remember. So if this is the abdomen, this is the bladder, you inflate it, you deflate it, then you attach you can say IV fluid, and you push at least 250 ml of fluid inside this bladder, and then you connect it with a infusion tube, and you see how far this fluid has gone. Suppose if this fluid is gone up till here, this will be in centimeters of H2O. Is that clear? And why it is so? Because the abdominal pressure will be applicable on this bladder also. So external pressure will compress this bladder, and bladder will allow the fluid to ascend a height. So you can convert the centimeter of H2O into the mm of Hg. So this is one thing. Then, whenever there is circulatory failure, or you can say loss of perfusion, there will also be ischemia. Try to understand the stress-induced gastritis. Yes, you can see the acid pH or pH going down in this case. So gastric tonometry is again one way. But again, when there is circulatory failure, you will see that there is decrease in perfusion also. Near infrared spectroscopy. All these are the ways of actually confirming the abdominal compartment syndrome. Management is for grade 3 onwards. Yes, you will have to go for surgery. Yes, or any grade if there is associated with head injury. So if there is head injury or there is increased intracranial pressure, but in any grade you will go for surgery. What is the surgery that you do? Decompressive. Excellent, Neeraj bachche. Excellent. Decompressive laparotomy. Decompressive laparotomy is done. Let us quickly move forward and let us start with some important golden points on trauma also. Yes, trauma. When you talk about trauma, yes, trauma. The most important thing, apart from this revision session, do take my revision session on GIT. वहाँ पर मैंने GI bleeds पढ़ाया हुआ है. So I have taught GI bleeds in my last revision session. Do see that also. Do study this also. And whatever will be left, I have planned for one more session. So that I will again arrange and I will cover up everything. Don't worry. Cumulative, it will be a 6 hours content, and those 6 hours, they are more than enough. More than enough. Yes. So when we talk about trauma, try to understand one very, 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 very important thing. Thoracic trauma, we have important things like thoracic trauma. We will be discussing thoracic trauma. We'll be discussing abdominal trauma. We'll be discussing abdominal trauma. We'll be discussing urotrauma. I'll be discussing neurotrauma also, and I will be discussing neck and spine injury also. Neck trauma plus spine trauma. So itne traumas I will be discussing with you. So let us quickly start. Yes, let us quickly start one by one. So when we talk about thoracic trauma, when we talk about thoracic trauma, all the important things I will be discussing with you. Thoracic trauma. I hope you remember the first thing that you get in thoracic trauma. You get questions. Okay. Someone has said, current damn bad students, but some of your videos from AIMS capsule. Okay. Okay. Deep, it's so Deep. Yeah, it's so good of you. God bless you. Bache, you can get more than those videos for free on Unacademy. So join Unacademy special course. It's free of cost for all, and you'll get everything there. Dams mein to I was not teaching GIT in all the centers, in few centers. Here I teach everything. And since there is no time constraint, I teach everything in that same swag. So when we talk about thoracic trauma, some important things that you have to understand. They are, you have to know about you have to understand the concept of life-threatening injuries. There are two categories. There are immediate life-threatening injuries. You get questions on immediate life-threatening injuries, and you get questions on what are the potential life-threatening injuries. Based upon this concept of what are immediately life-threatening injuries, what are potential life-threatening injuries, we decide how to approach a patient. Try to understand when we talk about the patient's approach. Try to understand the first thing is you should rule them out at primary survey. Is that clear? So rule them out at primary survey. Is that clear? So rule them out at primary survey, and therefore they are considered as lethal 6. What do you mean by lethal 6? They are the 6 life-threatening conditions which should be ruled out at primary survey. And then we have some conditions which are potentially life-threatening, so they should be ruled out. Post hemodynamic stabilization. So post hemodynamic stabilization, and there we have some conditions which are known as hidden 6. So hidden 6 and lethal 6 ये concept होता है. If you go through my notes of trauma etc., yes or no, try to understand. Like this year AIMS, there was INICT, there was a question on triads. They have asked the definition of triads. If you people have studied the general surgery from me, whenever I teach triads, I always write the first word. Triads means to what? To sort. And that very same question was there. And but this thing is not available everywhere. It is my own way of, you can say, teaching. And why will someone tell you the explain what the meaning, etc.? So they have asked this question of Triad. Like someone has asked, Sushmita is asking, flail chest. Flail chest is potential or immediate? Now let me tell you, flail chest is considered important. What is the confusion? Yeah, important is controversy. This is the controversy also. Controversy. Flail chest students is considered to be potentially life threatening. This is a potentially life threatening. Is that clear or no? Potentially life threatening. Why? I will explain it to you. And remember, there is something which is known as condition which is known as massive air leak. Why massive air leak happens? Massive air leaks. No बच्चे कुछ हटाया नहीं गया. अच्छा अच्छा. Okay. You are answering. I'm sorry. Massive air leak. If you talk about this is tracheobronchial injury. So tracheobronchial injury. बच्चे according to ATLS, this is considered as immediately life-threatening condition. According to UK, yes, UK concepts, yeah. So if you read Bailey and Love, yes. So nice guidelines. वो लोग क्या follow करते हैं? They use nice guidelines. Yeah? According to nice guidelines, they say that this is to be considered as this is to be considered as potentially life-threatening, or they use the word as lethal hidden sick. They use the word as hidden six. Now this is beyond the scope of this class, because in my routine class I take this topic for a lot of, you can say, for a lot of time. But I will quickly tell you that tracheobronchial injury, students remember, क्योंकि ये question भी आ चुका है. Tracheobronchial injury is any injury involving trachea and the bronchial tree. If it is involving the carina, it is type 1. So type 1 injury is involving the carina. And remember, type 2 is more than 2 cm away from carina. More than 2 cm away from carina. If there is any injury, that will be known as type 2 injury. We all understand that strategically, carina is the most common site for injury. It is the most common site for injury, and therefore any leak here is going to potentially, it's going to increase the threat of life by causing a leak of air. Which God also knew, and that is why you should understand that strategically this is important, but this area is covered by a mediastinal fascia. Therefore any leak here is spontaneously sealed with this mediastinal fascia, and therefore majority of the small leaks don't even present. So if you talk about, not all the patients of tracheobronchial injury will require a surgery, will present to you with respiratory distress. Why? Because of the presence of this mediastinal fascia. And I also approve this concept of mediastinal fascia, and this mediastinal fascia acts like that omentum which actually seals the leaks. You must have heard that peptic perforation, majority of the peptic perforation, they are even sealed. You don't get to understand what has happened. So mediastinal fascia, yes, it seals small leaks. It seals small leaks. Now when we were talking about confirmation, investigation of choice is always a flexible bronchoscopy. So we go for a flexible, not rigid. So flexible bronchoscopy, and try to understand. Flexible bronchoscopy तो तभी कर सकते हैं. Yes, you can do only flexible bronchoscopy when the patient is hemodynamically stable. Are you getting this point or no? Let us quickly try to understand. One beautiful concept of flail chest. But 2-3 points on flail chest also. So when we talk about flail chest, first of all, there are a lot of students who are confused between the counting, the criteria. Yes, what is the criteria? It is criteria is fracture of 2 or more consecutive ribs. So fracture of 2 or more consecutive ribs. Yes, at 2 or more places. So fracture of 2 or more consecutive ribs at 2 or more places. This is what is known as flail chest. This is what is a classical example of flail chest. Earlier, we used to read 3 or more. If you read nice guidelines, UK based books, You can say Bailey and Love, you can say Kusheri, you can say Churchill. इन सब में अभी भी 3 and above लिखा है, लेकिन it has been seen fracture of 2 or more ribs. Or remember, or one more criteria. Yes, detachment, yes, of even one costovertebral junction. Yes, or you can say costosternal joint. So costosternal joint. So detachment of any one costosternal joint is again sufficient to produce this concept of flail chest. Remember, everyone knows, I'm not going into depth of that. What is concept of flail chest? This is a flail segment which is totally detached from its what? Rib cage. Yes, and therefore flail segment shows paradoxical movement. So because of this flail segment, it shows paradoxical movement. What is this concept of paradoxical movement? Try to understand. During inspiration, the pressure is decreased on the thoracic side, so this is sucked in. Vice versa happens during expiration. When the pressure is increasing, it is thrown out. During inspiration, you know, the normal rib cage will move out, whereas due to negative suction pressure, the flail segment will go. So isn't it like it is actually doing opposite of what it should be doing? So flail segment shows paradoxical movement, and because of this paradoxical movement, what happens? Do you know? There will be stretching of nerves. So try to understand. So during inspiration, expiration, if the rib cage is moving like this, there will be no strain. If it is like this, there will always be a strain, and thus what will happen? There will be stretching of intercostal nerves. So during paradoxical movement, there is stretching of intercostal nerves, and because of the stretching of intercostal nerves, there is extreme pain. And because of this extreme pain, students, what is going to happen? Yes, there is compensatory, because flail segment will not do anything because it's totally detached. So there is compensatory decrease in rib cage movements, and if the rib cage movement decrease, you know, the ventilation perfusion will also be affected, because there will be impaired ventilation perfusion. Yes, so therefore there is ventilation perfusion mismatch. So impaired ventilation, and because of this impaired ventilation, you develop what? VP mismatch or respiratory distress. Therefore, since we see that the condition is because of the pain, the first line management or the treatment of choice is actually the painkillers, or you can say the NSAIDs. Remember, only few patients require a ventilatory support, so with PPV. Now, because of this same reason, people used to say, since it can be cured with NSAIDs, it is not to be considered as a life-threatening injury anymore. But these people are moron, because उन्हें पता ही नहीं है. The problem is not this. The problem is the lung is moving in and out. Yes or no? And this is a broken rib cage. But normally this is the alignment. Therefore not a problem. Yes or no? Suppose if I give you a balloon. Yes or no? And if I give you, this is a pointed stick. Yes or no? And if I ask you to touch this balloon like this, if you see their axis, try to understand. Physics is everywhere. Try to see their axis. Yeah. So this is the axis of balloon, and this is the axis of the stick. But aren't both the axis what? Yes, you can say linear. They are coaxial. So this arrangement को हम कहते हैं coaxial. Yes. If you want to stab someone into the abdomen, their axis should always meet. So 90% of the cases, since the flail segment and the lung, they are coaxial. Therefore, very less risk of perforation of the lung. Remember, very good. Remember, if this is the lung and this is the axis, this is the flail segment. So in this case, if you see one very beautiful thing about them, this is the axis of the balloon. You can say axis of the, you can say the rib, and this is the axis of the. So this is always going to perforate, and if it perforates the lung, you have to go for thoracotomy and repair. So try to understand, not all patients will have pulmonary contusion, so therefore not all the patients should be considered as what immediately life-threatening conditions. The flail chest should not be taken as immediately life-threatening thing. Are these points clear to everyone or no? Yes. Remember, we don't go for any form of external banding or strapping. Again, very quickly we will understand the concept of tension pneumothorax also. When we talk about tension pneumothorax, what is happening in tension pneumothorax? Remember, the first thing is there are still students who are fighting with this concept. Tension pneumothorax kuch bhi nahi hai. It is an ordinary pneumothorax given some extra weightage. Why it is given some extra weightage? Because of this hypotension. So any pneumothorax where hypotension has developed, this is what will be called as a tension pneumothorax. What is the concept of tension pneumothorax? The concept of tension pneumothorax is damage to what? Damage to what? Parietal peritoneum or visceral parietal pleura, visceral pleura. Damage to visceral pleura. And this visceral pleura which has been damaged, yes, it acts like a valve. It acts like a flutter valve, and this is actually going to create all that problem. Now, बच्चों देखो, this is what is the lung. Yes, try to understand. Yeah, this is the flutter valve. This is the flutter valve. So all the air which is entering, will exit into what space? Will exit into, yes, the pleural cavity. Why pleural cavity? Because the pressure of the pleural cavity is generally negative. So all the air will go. But when it comes to the recedement, you can say when it comes for the return of the air is stopped. Why? Because of this valve-like action, because of this valve which has been created by the damaged what? Pleura. Are you getting this or no? But because of this, what will happen? Remember, the lungs will be overinflated in the pleural cavity, and there will be compression of the underlying lung. So ये जो negative pressure zone था of the pleural cavity is now the positive pressure zone, and the first thing that has happened is compression of lung. So compression of lung, if there is compression of ipsilateral lung, therefore the first thing that is going to happen is respiratory distress. Since there is overinflation of this lung cavity, therefore students, there will be flattening of diaphragm. And because of this flattening of diaphragm, there will be again respiratory distress. Also try to understand, there is air in between two layers. So air in between two layers will give you that typical eggshell crackling sound when you press it. What is that thing known as, students? Subcutaneous emphysema. So subcutaneous emphysema is what you are getting. Remember, the word subcutaneous is a misnomer because it can occur at any place, and because of this it is going to exert a lateral traction on the lung. When the lung is trying to go away, but the contralateral lung is not allowing the lung to go on that side, and therefore in between them the lung will be compressed. So there is compression of the lung, compression of the heart. So if there is compression of the heart, I'm saying lung. So if there is compression of the heart, what will happen? There will be increase in the back pressure. First of all, there is increase in the back pressure. So if there is increase in the back pressure, what will happen? There will be increase in CVP or JVP. Is it clear or no? Try to understand. If there is compression of compression of heart, there will be decrease in cardiac output, and therefore you get to see hypotension. Also there will be tracheal deviation to the opposite side. So hallmark is, if you talk about the concept of, you can say, tension pneumothorax, one very important thing that you have to understand, any pneumothorax can be called as tension pneumothorax if there is compressive version of cardiogenic shock. Try to understand, as the patient worsens, what will happen? As the patient worsens, what will happen? The lung will keep on inflating more and more, there will be too much lateral traction on the heart. So what will happen? There will be a partial twist and a kinking. So due to excess lateral traction, what will happen, students? There will be a partial twist or kinking of vena cava. So there is a twist or a kink along the vena cava, and this is going to block the inflow. So if there is a blockage of inflow, what is it going to do? Yes, this is going to cause arrhythmia, and then you know everything. What is that? Yes, tararara and tararam pam pam. Yes. So one thing which is very important, that the cause of death here is obstructive cardiogenic shock. So obstructive cardiogenic shock is the cause of death. Are you getting? Remember, what is the treatment protocol? It is very simple and straightforward. The only thing we want is the air which is accumulating in this pleural cavity should be evacuated out. Yes or no? So treatment, let us talk about treatment. If the patient is stable, put an intercostal chest drain. Yes, intercostal chest drain. So tube thoracostomy. So you are connecting the tube to the thorax. So tube thoracostomy. And where do you put this tube thoracostomy? Fifth intercostal space, at the fifth intercostal space. Yes, via triangle of safety. Are you getting this? Via triangle of safety. We're going for tube thoracostomy. 2-3 questions are asked. What tube that is we use? We use the tube of size 28 to 32 French. 28 to 32 French tubes are generally used. If the patient is unstable, can you see this patient? Suppose if the lung has overinflated, you will not be able to estimate the time. When this lung and the heart interact in a way that there is kinking of the vena cava and the patient passes away. Why it is happening? Because of the accumulation of the air. So बच्चे हम क्या करते हैं? To buy some time. So if there is unstable patient, the first line is put a needle. Yes or no? Very good rhythm, bachche. So you go for needle thoracostomy. Yes, excellent, Sudha. Excellent. So needle thoracostomy. Remember, we use a spinal needle. Simple spinal 25G needle is what we use. And then once it is stable, so you have to go for followed by tube thoracostomy. Is this point clear to everyone or no? So ultimately we have to do. When you talk about the needle, बच्चे needle, ये needle आप fifth पे भी कर सकते हो. You can do at fifth, or in case of kids, you can still do in the second intercostal space along the mid clavicular line. बच्चे nowadays the recommendation is yes, go for a fifth intercostal space only. Fifth intercostal space via triangle of safety. Let us quickly move and understand one more important condition related with this. Whenever you have a patient with thoracic trauma, and along with that you have engorged neck veins. So you have thoracic trauma, engorged neck veins, that means there is increase in CVP. Along with that you have hypotension. What is the classical differential diagnosis? You all know that this is a case of okay, so there is hypotension. Yeah, what is this case of? Tell me. You have two differential diagnoses. Very good. It could be either a tension pneumothorax, Either it could be a tension pneumothorax or it could be a cardiac tamponade. Cardiac tamponade. Bache, how to check this? Bache, there are only two parameters which are very, very, very important, because a patient is having engorged neck veins as well as the hypotension. So the first thing that you have to do here is you have to go for assessment of or auscultation of. So auscultation. So you go for auscultation of cardiac sounds and auscultation of breath sounds. So auscultation of cardiac sounds and breath sounds. बच्चे क्लिनिकली मैं बता रहा हूँ, उसके बाद वो तो बेड साइड आप लेके आओगे, वो एक अलग बात है, अल्ट्रासाउंड टू गेट इट. So tension pneumothorax, heart sounds are absolutely normal, but the breath sounds are decreased. In tamponade, the heart sounds are decreased, rather they are muffled. You know why? Because now the media is the, what you can say, clot, and clot is acting like a sound dampener. It's going to dampen the sound. So muffled breath sounds, they are absolutely normal. So this is what is going to be very, 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 very important. Further, how can you confirm? Yes, confirmation, bedside confirmation if you want. Bedside confirmation if you want, you can do a E-fast. E-fast is the easiest way to confirm it bedside. Yes or no? Then what is the management? If it is found to be tension pneumothorax, management I have already discussed. This is the management I have already discussed. If it is a tension pneumothorax versus cardiac tamponade and it is found to be a cardiac tamponade, you know the first thing is USG guided, yes, pericardiocentesis. When we talk about this USG guided pericardiocentesis, what is the next thing that we should be knowing? Yes, pericardiocentesis. If after that, what is the status of the patient? Status. If it improves, then you will have to go for observation. If it worsens, awesome, bache, awesome. If it is worsening, you will have to go for thoracotomy. When you plan thoracotomy, what is the important thing that you have to, when you do a pericardiocentesis, students, this is the subxiphoid. Space. So you will place the probe at the angle of 45 degree, and under the USG guidance, you will advance your needle also. So under this guidance only you will advance your needle into the pericardial space, and from there you will take out. Yes, awesome बच्चे, awesome. 45 degree angle पे आप करते हो under the USG guidance. What needle is used? Again 25G spinal needle is used. So 25G spinal needle is what we use. Apart from that, let us quickly discuss one more concept of thoracic trauma, that is massive hemothorax. When we talk about massive hemothorax, two things that you should be knowing. What is the criteria? For massive hemothorax? Answer is more than 1500 ml. Yes, blood in the thoracic cavity. So more than 1500 ml blood in the thorax in case of adults, or more than 25% of blood volume. 25% blood volume, yes, in case of kids. Try to understand what is the management of massive hemothorax. So when we talk about the treatment of hemothorax, this is same as the management of pneumothorax. This is same as the management of pyothorax. Bachche, in all of them, very good Nandi bachche. In all of them, the first and the last thing that we do is put a needle, put a drain. So this is tube thoracostomy. So tube thoracostomy is what we do, and remember this is done through the fifth intercostal space via triangle of safety. But when it comes to massive hemothorax, then the question is, Should we go for conservative? Answer is no. So let us understand what are the indications of thoracotomy. What are the indications of thoracotomy for hemothorax? The first important point that you should be knowing is massive hemothorax. Massive hemothorax. So first point is massive hemothorax. The second important point is, suppose if it is not, you're not knowing anything, you went for tube thoracostomy, something came out, that something has to be assessed, and that is what is known as initial. So initial tube drain output, initial tube drain output. So students, if initial tube drain output is more than 1500 cc in case of blunt trauma, automatically it qualifies for massive hemothorax. Or in case of precision wounds like penetrating injury, yes, so more than 1000 cc in penetrating injury, in penetrating trauma, this is what is important, very very important. If a penetrating injury is having more than 1000 cc of blood, this means that you have damaged something very vital. Then third is yes, suppose the drain output was not that much. So drain output you are seeing, so drain output more than 200 ml per hour for 3 consecutive hours, for 3 consecutive hours. Awesome bache, awesome. God bless you, Shushmita. Having really very good preparation. All the students which have attended this class, I'm seeing 90% of the students, they're awesome. They're awesome. So I will just say one thing. There are so many good students in this class. It would be prudent if I name or only few. That all of them are very good. But just continue this hard work. Don't take any stress for the exam. Definitely you will crack it. Definitely. अगर आप देखोगे तो 90% of the questions और 80% of the questions ये जनरल सर्जरी और ट्रॉमा वाले पार्ट या बर्न से ही आते हैं. And I'm seeing that students are rampantly answering beautifully. Yes, सब कुछ बताते जा रहे हैं. And this is really very good. Really very good. So drain output more than 200 ml per hour for 3 consecutive hours. That indicates that something vital is bleeding. Something vital is bleeding. And this is an indication to take a call for surgery. Next is very good. Most of you have answered caked hemothorax. When you talk about caked hemothorax, what is criteria for caked hemothorax, students? It is a clotted hemothorax. Most of you have answered more than two failed tube thoracostomies. More than two failed or two, yes, two failed thoracostomies. Thoracostomies. Yes, definitely, Shushmita, take surgery, come to my hospital for fellowship courses. Even if you will take gynecology, yes, you can come to my hospital to learn TLS. Like I'm actually doing a lot of gynecological procedures also, no? Like total laparoscopic hysterectomy, cystectomy, ovarian cystectomy, birth corpus suspension, tubal recanalization, सारी करता हूँ. Yes or no? So you can come to my center to learn these surgeries, and it will be always a fun. Next is the last thing that I'm going to discuss for today. So tomorrow maybe again I'm having one class, and day after tomorrow again I'm planning all the classes. I think I'll change the time to the evening part only. Yeah. So yeah, cardio surgeon. Yeah. God bless you, bache. God bless you. Definitely, you can always come. Yes. Next is, so we have diaphragm injury. देखो, I never call myself a teacher because मैं teacher हुई नहीं. A teacher is someone who is very sincere. Yeah, sincere. I'm not a very sincere person. बस चल रहा है काम, इसी तरीके का हाल है. Yes or no? But I actually love my branch a lot. I am passionate surgeon. मेरे लिए सब कुछ अलग. Surgery is something which is very important. The days I don't have blood on my fingers, I actually don't like that day. मुझे लगता है यार कुछ भी नहीं हुआ है ना. So diaphragm injury, if you talk about, I don't know how people don't actually practice and then they actually teach surgery, because actually a surgeon without a scalpel is you can say a man without a spine basically. There are people who actually fear. Yes. So diaphragm injury can be associated with penetrating injury or can be associated with blunt trauma. So can be associated with penetrating injury, can be associated with blunt trauma. Yes. So when will you suspect penetrating injury? Yes, association. Association. Yeah, association. So बच्चे, any penetrating injury, yes, at or below, fifth intercostal space. Yes, fifth intercostal space. So whenever, I think this was the question also asked. So whenever you have any penetrating injury at or below, something penetrating at or below the fifth intercostal space or lower part of the chest wall, I think this was a question on NICT. Always think of diaphragmatic injury. You have to rule out diaphragmatic injury. Yes. Let us try to understand the blunt trauma concept. Yes. Blunt trauma concept. Diaphragm injury and the liver injury. Yes. Blunt trauma, this is associated with fractured ribs. This is associated with fractured spine. This is associated with fractured pelvis. कौन सा? Yes, compression type. Compression fracture pelvis. Compression fracture pelvis. Yes, very good. Very good. And I hope we have tried also. Yes. Can you tell me the name of the triad? Can anyone tell me the name of the triad? Where you have fracture rib, yes, fracture spine, yes, fracture rib, fracture spine, or fracture pelvis. Come on, tell me. And along with, yes, excellent, and diaphragmatic rupture. But this is what is known as Bergquist triad. This is what is known as Bergquist triad. Where do you see Bergquist triad? Bergquist triad is seen in case of, yes, in case of, you can say, blunt trauma associated rib fractures. Diaphragmatic injuries. Now, when you talk about the management, the investigation of choice is an invasive investigation. And what is that invasive investigation? Answer is, it's a laparoscopic. And what is the advantage of laparoscopy? It's 100% accurate, 100% sensitive, and 100% specific. So diagnostic laparoscopy. What are the advantages? If you talk about 100% sensitive, specific, and accurate. Not only this, it is also diagnostic plus therapeutic. If you see an injury, simply put one more port, take a needle holder, take a Maryland, and do the repair. Finish. That is done. Yes or no? So investigation of choice is a diagnostic laparoscopy. This is preferred over CT scan. So over CCT abdomen or maybe a HRCT thorax. Is that clear? Let us talk about the management. Important is all diaphragmatic injuries require repair. Remember, all repair. Simply you can take Proline 4O or Proline 3O, or you can take a Vicryl and just repair it. Yeah. Proline में laparoscopy में we rely more on Vicryl, not on Proline, because Proline, it's very difficult to manipulate. It's having a lot of memory. So हम उस case में we take what Vicryl. If it's a large diaphragmatic rupture, we put a mesh also. We can use a Gore-Tex mesh also. So all repairs done via abdomen. Why the repairs are must? Try to understand. Today the patient is stable. Yes or no? This is a small injury. But try to understand, diaphragm is always a constantly moving structure, and you will not get to understand when this defect has turned big. And what can happen, students? Yes, a viscera can go, and there will be adhesions at this level, and ultimately what will happen? Strangulation, perforation, and mediastinitis and peritonitis. So I hope you people enjoyed today's lecture. I'll be taking many more such series for you people. Always remember one thing, that surgery is very easy subject. You have to concentrate on your basics. सर्जरी एक ऐसा सब्जेक्ट है जो सबसे इजी है. but you have to concentrate on your, what you can say, on your basics. I'll discuss a lot of things. Remember, join my telegram group, and my telegram group ID is SX Dada, SX space Dada. Yes or no? Also, you can join, please join Unacademy plus courses to have the maximum mileage. So my all my lectures are there. All my lectures are there. I take live classes. We have pre-recorded. We have PDF forms available. Yes. So use Dr. Dixit. Yes. To join the special classes. To join the special classes. And if you like it, yes, then only go for the plus classes. So plus course and special class. There are a lot of small offers also going on. You can always join them. And do join my telegram group. What you can do, once you download the app, follow me on Unacademy. So follow me on Unacademy. What is the advantage? Any of my special class, you will not miss a notification. Is that clear? So I hope you enjoyed. I also enjoyed. After so many days I have taken such a long session. So it was just like I went back, went into flashback, because previously when I was taking classes in my previous institute, I used to take classes for 4 hours, 5 hours, 6 hours at a stretch also. तो समझ भी नहीं आता था. Why? Because live interaction is so, you can say, mesmerizing. You don't even come to know. You don't even come to know how 3.5 hours pass. Like today it happened in virtual class also. We are sitting and enjoying. I saw most of you started from the from the first, you can say, first minute of this class, and then it's awesome. But it's so great. Yeah. So God bless you everyone, and just keep in touch. Let's say platforms really don't matter. It's the relation between me and you. So I be in dams, I be it in Unacademy, it hardly matters. I'm just enjoying my journey of life with you. Yes. So we will always be friends together, and we will always enjoy this subject. And I want you people to take surgery as the brand, because there is nothing better than surgery. This is my perspective, and you also will enjoy. Yeah, every day there is class. I have some revision classes going on in special also, and plus also, and on YouTube also. I'll be taking class. So I'll notify that on my this what Telegram channel also. Okay. So till then, bye bye, bye bye, bye bye, bye bye.